Welcome all to this event that we call Sustainable AI to Drive Global Health. Today we're at Goka House in Gothenburg, Göteborg for the Swedes, and we are very excited to have so many people, knowledgeable people here in the room, as well as you following us online in the audience. We are 4 partners that have organized and prepared this event. We're FEAM, the Federation of European Academies of Medicine, via the Biomedical Forum. We have Astra Zeneca, and we're also close to their home turf. And we have AI Sweden, and then at last KTH, where I work myself as a professor. Looking at the title, Sustainable AI to Drive Global Health, there are 2 aspects that I would like to problematize a little bit now at this kickoff. At first, there's the word of sustainable. Sustainable AI, if you could think maybe in 3 ways about that. First of all, the long-term sustainability of AI as a tool itself. How do we make sure that if we develop it, that it continues and can be used in the long term? There's also the contribution of AI to the sustainable transition, as well as how do we secure sustainable impact of AI, not as a tool itself, but also the ways we implement it. Then there's the word global health, and we specifically choose this, but because the EU is not just only a producer, it is also a consumer to a certain extent of AI models. We all want to have the EU thriving and the EU prospering by having a healthy industry, healthy citizens. But where do we need to be in the lead? How do we relate ourselves to other countries? To what extent do we want to export the things that we develop here to, for instance, low-income countries? But also, how do we deal with the values systems on which AI models are developed? If we look to the east and to the west, do we want that? Do we need it? To what extent should we position ourselves? I believe we are at an interesting point in time. The AI Act and the European Health Data Space Regulation have now been put forward. They are in different stages of decision making, but we know so much better the contours. If we look back just 1 year, we would have had a very different and much more confused discussion, I believe. But now that we know more or less where we're going, what are the next steps? Where should we put our energy? These are the things that we jointly need to discuss here today. I noticed a lot of excitement in the preparation towards this event. The motivation to keep the EU competitive, to keep the EU in the lead, as well as doing good for the Sustainable Development Goals, particularly goal number 3, global health. This excitement is there. We need to do this right now with society. Particularly if you, for instance, have more somber economic outlooks. This could help, potentially. But a basis for this we identify is this triangle of trust. The triangle between the citizens, the public sector and the private sector to all drive forward this agenda. How can we make sure that AI really contributes to us? And, well, I'm a professor, and one of the things that I observe is that we don't even trust our own students with ChatGPT, and we go back to handwritten exams. Is that the response we want to have? Today, I hope that we can have some visionary discussions. But visionary not only in the very long term. The reality is from here and forward. And what we want is to result in is a form of a white paper. We'll have multiple people taking notes today. It is online. You're very welcome to follow and also to provide your inputs from online. We have 2 moderators. There's a human firewall between the online and me, so to say, which means that if there are questions that need to be put into the discussion, they will come on a physical paper, which is nice in the digital setting, I believe. The white paper is something that we'll produce after the event. And therefore, I hope that we can have a dynamic discussion, because this is not a meeting where we want your official position on something. We want you to think, what's next? Where do we need to put our efforts? That being said, we know that some people are still in traffic, so you might see a small shift here and there in speakers, but the setup of the day will be before the fika, yes, coffee with something to it, you're in Sweden. Before the fika, we'll have a setting where we put out, like, what are the long-term evolutions that we see? What are the visionary things to which we want to strive? After the coffee break, and for you online, I hope that you can arrange your own kanelbuller, and maybe it is possible to even put up the recipe for you online during the break. But after it, we'll have 2 panel discussions here that will be interactive. I am really excited. I've prepared with all the people being part of this in advance, and well, I think it's a wow with the number of perspectives and the brain capacity we have here. With that being said, have a great day. I would like to invite Peter Blomgren then to the stage to start with the perspective from industry. What are the things that you see? Where are we going? Peter.
Thank you very much. It is a pleasure to welcome you and to be co-hosting this event as well. I really believe in the collective brain, and this exercise is an experiment of that. So hopefully we can put our neurons together and get a good outcome of this. Health sector is, of course, a priority area, and the whole sector is moving in this space. So it's natural for us to put the focus on this, and for Astra Zeneca, it's clearly the case as well. We have a very ambitious sustainability agenda and have been pioneering in responsible data and AI as well. So good combination. For the past 2 days on the main event on sustainable AI for sustainability, there's been many great takeaways and some aha moments as well for those of us that were there. One of the things that I observed is that we still tend to think about AI as something for the future, and that we need to focus on how to deal with the risk. So that makes me extra glad to be here and share some examples of how it's being used here and now for taking medicines to patients faster, and also, of course, what we see going forward. And that it is possible to do these things, both pushing the boundary for benefits, looking for the purpose, the drive for doing it, as well as doing it in a responsible way. And this balance, I think, is another theme that came out of the 2 days in the main conference. So, looking forward to the collective brain exercise that we'll do. Let's see if we could. Oh, there it is. That was that conversation. So, what are we then doing from the industry perspective? Well, there is opportunities with AI across the whole value chain, and from target discovery through to how we deliver and monitor, and loads of opportunities in this space. And of course, there is various adoption of this, but it is a prime means to get medicines to patients faster. And I think that's realized across the sector. And then we do it in different ways and to various degrees. For AstraZeneca, it is really embedded into the organization, and it's foundational to the company strategy. This is a slide from last week's where CEO talking to stakeholders and investors. So it's showing how embedded it is, and the impact it has on the whole company. So that's one of the key things here, that it is here and now, and there is further and huge potential for things to go forward. This is one of the examples that is being applied across many companies in this sector. So using AI for drug discovery, both to increase the knowledge of the biology, to understand targets and pathways, which is critical decisions in discovery, as well as to speed up the identification of leads. And we see remarkable improvements in here for small molecules, doubling the speed, and in biologics, it's massive improvements. So it's very substantial impact that it has, and we can see it happening as we speak. Another example of something that is often used now is how AI is being used to transform how we diagnose and how we use it for analyzing images. And in many cases, it's already as good as humans in doing this, and in some areas, like digital pathology, it's actually even faster and get higher quality results. So it is, again, order of magnitude. It's significant impact, and it's happening here and now. So for AstraZeneca, it's a foundational element of the company strategy. And what does that mean? Well, it means we apply it across the company, and it means we're applying it to the most challenging nuts to crack. So this illustrates what we're facing. It's going from sick care to healthcare, and that means you have to come in at an earlier stage and be more precise with the medicines that is being provided in order to break the circle. So there is a load of potential in this space beyond what we're currently doing. Here's one example of diagnostics and being able to scan the retina in order to predict the cardiovascular risk factors is something that not only can be a complementing way of doing things, but also connects to the sustainability aspect. So access to healthcare in development countries where you don't necessarily have the means that you can use. So this is now being applied in an initiative that we have in Africa to help drive access to healthcare for people that otherwise wouldn't have it. Another thing that can be used is for using AI for predictions, so that you can avoid doing invasive sampling. And of course, for those of you that have tried it or have close ones that have, that is a very desirable thing to avoid, as well as open up for a broader population to actually be able to get the benefit from it. A third example is using AI for vocal biomarkers. So we're currently developing this for cough. So again, a good example of where you can complement, make it easier for the patient, or use it for a population that may not have the traditional methods, like in China, where spirometry is a scarce resource and competence. If you have a vocal biomarker, it means more people can actually get access. So we see very tangible results in this. We measure both financial and non-financial impact and driving indicators like number of projects and access to data and people and underlying training. So there is tangible effects across the company, and we see this across the sector in various means. What I mentioned before is, it's really important to both drive with a purpose, so you know what you apply to, that it makes a difference in the business, but also do it in a responsible way. So I think the sector has been early on in this in comparison, and Astra Zeneca definitely so, being first pharma out with AI ethics and a position on responsible data and AI. But I think again, it's our collective knowledge that we need to push forward. And as an example for this, one of the next steps we're doing is to actively, voluntarily engage with regulators for inspection and audit, and then to share our experiences around this, so that we continue to build that collective knowledge and understanding, so we can move the field together in this space. And I think, connecting back to the conference again, one of the themes that came out is we have to have this balance of the purpose, the how you apply it into the work that you do, and how you mitigate the risk. So it is possible to push the boundary for benefit and secure responsible data and AI use, and we need to find ways of making this happen in practice, as we have been applying it in AstraZeneca and sharing things across, and we see colleagues around the sector moving in this space. So really looking forward to what we can achieve together in this setting today, bringing our collective minds and brains together to navigate us forward.
Peter, really nice. If I could ask you a question. With the forthcoming legislation, do you see that the trust in industry can be taken up? Is that sufficiently regulated or over-regulated, or is something missing from your perspective?
I think it is good that we get regulations in. We should be focusing on high risk and making sure that we complement what already exists. But I think what we should do and can do is to be open and transparent and work with the collective broadening of knowledge in the space. So I think the short answer is yes.
Well, that is a positive message if we now go to the political perspective.
Mm-hmm.
So thank you very much. With that, I would like to invite, and I know that you're fresh from a taxi, Tomislav Sokol, member of European Parliament, and very importantly, the EHDS rapporteur. Would you please come forward?
Okay.
And I know that you have a couple of slides.
No.
Only, yeah?
No.
No?
No.
Then the floor is entirely yours.
Okay.
Please tell us your perspective. I guess that if you're over here, I did it wrong as well, then you don't have the projector here.
Okay. Yeah. Okay. Now that's better. Thanks. Yes, I have to apologize for being late because the taxi driver drove me to the other side of the building when there are building work, so it took some time until we sorted it out. But now everything is fine. Thank you for inviting me. So I think it is scheduled that I just give a short introduction to the EHDS, and then afterwards we'll have a discussion, the round table. So European Health Data Space, that's one of those few pieces of EU legislation which really creates something new. So the whole idea is that we create this European health data space where data could be interoperable, could be exchanged, and could be used both for primary purpose and for secondary purpose. Of course, now we know that we have 27 different member states, 27 different systems, 27 different ways of using data, protocols on using health data, standards, etc., different ways of interpreting the GDPR, and all of this makes it very hard to use health data in cross-border setting, to use big health data sets for research, etc. It's not just 27 different systems that we have, but we actually, within some member states, like federal member states where healthcare is regional competence or lower level competence, even there have problem of exchanging data and having different rules of the use of data, etc. So the whole idea is to change that. So the whole idea is to have the whole European Union as one health data space with the same standards, with the same ways of using data, with the same protocols, and in that way being able to really utilize the full potential of data. We saw during the COVID-19 pandemic how important it is to have common rules on the use of data. For instance, it was very hard to compare data on mortality from COVID, for instance, etc., from different member states, since they had different rules, different standards, different ways of calculating the numbers of deaths, etc. So that's just one example. So the whole idea of the health data space is to regulate two dimensions. First is the so-called primary use of data, and the second one is the so-called secondary use of data. So primary use of data is the use of data for healthcare professionals. So the whole idea is that we have that health data of patients is digitalized, that will have one electronic health record system across the EU with explicitly prescribed data which goes into that system, so it will be the same everywhere. So, and this European health record will then be available to medical professionals who treat patients anywhere in the EU. Which means, for instance, if you are traveling on a business or for studying, etc., from Sweden to Italy, for instance, and then you have to see a doctor, that doctor will be able to access your electronic health records, see, for instance, if you had any previous diseases, if you had previous diagnostics, treatments for something, etc., whether you're allergic to certain treatment or medicine, etc., and then we'll be able to prescribe you with therapy much faster, much easier, much more efficient than if having to go through some of these things all over again. So the whole idea is not to duplicate things, to make healthcare provision much faster, much more efficient. Of course, since EU is regulating this is especially relevant for cross-border situations, because European Union is primarily competent to regulate cross-border healthcare situations. But of course, also within a member state, if we have this common standard of electronic health record, there is no reason why this cannot be used also within a member state. For instance, let's say that you are you're in Stockholm for a business trip, you have an accident there, you have to go for a surgery, etc. Then after, let's say, 3 or 6 months, you go to your doctor here for a regular checkup or something. The doctor will be able to access everything that they've done in Stockholm when they operated on you, prescribe you with additional medicine or something like that. So of course, EU, as I said, is primarily aiming at regulating cross-border situations, but which involve people traveling from to different member states. But of course, this electronic health record will be able to be accessed and used, and it will be interoperable also within a member state. What is important, of course, is to preserve the most important principles of data protection as well, which means the GDPR remains to be applicable. That's important. And also what is important is that patients can also decide if they do not want part of their medical data to be accessed by some medical professionals. For instance, if they have some mental issues or sexually transmitted disease, etc., they can limit access to this data to only certain healthcare professionals who are treating that specific condition. So in this way, by giving patients the choice to limit access to data, we are also protecting their right to choose and also their right to privacy. So this is the primary use of data. I think there is nothing politically too sensitive on that. There will be technical things that we have to work out also during the legislative process, but essentially there should be no big problems with that. What I think is probably especially relevant for you, there's a secondary use of data. And here situation becomes a bit more tricky. So secondary use of data means essentially that somebody who is doing, for instance, research on something and wants to access large data sets from across Europe will be able to send a request to National Health Data Access Body. So each member state will be under a duty to have at least one health data access body. They will have to justify why they need this data for, what kind of research, what is the expected end result, etc. And then the health data access body will decide whether to grant access to this or not. So access will be granted only to anonymized, or in some cases pseudonymized data, and only within the security environment, and only for that specific, very limited purpose. So the whole idea of this, of course, is that we make available for research and innovation much bigger number of data sets across the European Union than it is possible now because of all these national different rules, regulations, etc. What is important is also that, as I said, that this is only for a very limited, very clearly defined purpose, that it is in a limited setting, and that what is crucial is that patients cannot be re-identified by using this data. So this is crucial. That their privacy, that their personal data is protected in a way that those who are doing research cannot re-identify individual patients by using this data. So this is crucial. So this is the whole idea. Now the situation is that when the Commission came up with the proposal of the regulation last year, they didn't provide for any role of the patients in terms of consent, in terms of opt-out, opt-in, or anything. And of course, that's something that politically cannot fly, because the elections are coming up. For many political groups will use this to raise political points, to present themselves as big defenders of patients' rights, etc., etc. So this is something that is a problem, because we see during the discussions in the Parliament a lot of populisms, let's say, on this issue. So, but definitely, what my position as the rapporteur for this file is that we need to give patients some kind of a role. So we cannot just take away their data without them having any say in this at all. So what I proposed in my first draft report is a so-called opt-out mechanism, so that those patients who do not want their data to be used for secondary purpose can decide not to. And we believe that this is the right balance between, on the one side, the need to let patients decide on their data, but also the need to have representative and useful data in the end, because we believe that with an opt-out mechanism we'll be able to give patients the right to choose, but also will be able to in the end have enough data, useful data that it can be useful. Because if we go for an opt-in, I think the biggest problem is that we will not get enough. Data. So that's the first problem. The second problem is that this data would not be representative, especially if you take into account some certain very specific targeted groups, where definitely you would not have enough people opting in, so that you can have data that you can really actually use for something useful. So this is why we went for an opt-out mechanism. But here we have the big political fighting, let's say, because some political groups, especially more to the left, let's say, as I said, want to score political points, and they are insisting on opt-in mechanism, or some of them even for a consent-based mechanism. That would mean that for each time somebody, for instance, Astra Zeneca requests a certain data set for research, that each individual patient whose data is included in the data set will have to give their individual consent. Of course, that will not. That would not work. So definitely there will be a lot of discussion of this, and if I can just extrapolate it a bit further, I think the general problem is also this political atmosphere in the parliament, which is not very, I would say, healthy towards research, innovation, and private sector in general. Because what we saw, for instance, when we had a discussion in the ENVI committee, in the Public Health Committee on this file, coordinator, so the main person from a socialist political group, from the Committee on Civil Liberties, said that we have to think about the patients, not the industry. So this is their logic. So patient on one side, industry on the other. Of course, we try to explain them that we cannot treat patients, we cannot have new innovation, we cannot have new medicines, treatments, etc., without the industry. So, but a lot of people in the parliament don't understand that. I personally, I come from a former communist country, so we know what happens if you only focus on public investment, if you don't have a private sector, etc. But we had this kind of an experiment for 45 years, as you know, it didn't end so well. So this is something which definitely my position and position of my political group, the EPP, the European People's Party, is that we need the industry, that we need to create this partnership, and what is important is also to do whatever we can to actually bring and attract investment to Europe. Because what is interesting is that, and absurd, is that people who are speaking about strategic autonomy of Europe on one side, on the other side are doing everything they can to prevent investments coming to Europe. So this is kind of this strange logic that we have with some colleagues in the European Parliament. So I think this will be the main issue. So it will be the main issue will be about opt-out, opt-in, etc. The second about the purposes for which data can be used, because some colleagues insist that we put a provision that no profit can come out of this. I mean, why would you do research if you don't have profit in the end as a result? So we'll have a lot of problems there. There are also even some ideas that because there will be certain fees that will have to be paid for administration of the system, etc. There are some ideas that private sector is charged more than universities, for instance, when they access data. Then you explain to them that legally that's impossible, this kind of discrimination. But there will be a lot of crazy ideas floating around, so we have to be prepared for that. Apart from that, I think so that this is the main issue that we'll have in the European Parliament. Of course, when you get to the member states and the council, the main issues will be about, first, the money. So member states will want more money for the implementation of the system. We agree with that. So the Parliament will also support that. And the second will be about the timeline for implementation. So member state, I expect, will probably want something in the ballpark around 9 to 10 years for that. Commission has come up with very ambitious proposal, which I think is not realistic. So probably in the end we'll have to settle for something in between, probably 4 to 5 years of implementation, something like that. But what is important for us, what we also proposed in the first draft report, is that in the governance structure of the whole system that will be set up, so the health data access bodies on national level, the health data space board on the European level, is that we also include stakeholders much more than it was proposed by the Commission. So here we propose to include both patient groups, which are very important for us, but also the representatives of the industry. And I expect that there will be also many problems with that, because I know that some colleagues also do not want the industry to be included in this governance system, but we believe that if we want to have a real governance system which will really know and how to streamline the implementation of the whole system, that all important stakeholders should be involved. I think with the GDPR, one of the biggest problems with the GDPR is that we didn't provide for good implementing framework and good implementing ecosystem, let's say, with good governance, and because of this we have these different interpretations of GDPR across the member states. So I think that we should try to avoid this. We should have this common unified unified system of governance, which will provide also guidance, recommendations, etc., how the system should be implemented. But because of this, it is also important that all important stakeholders are involved. That means healthcare professionals, the industry, and the patient representatives. But we'll have a lot of discussions also on that, as I said. But I hope we'll be successful in the end. And just to finish off the timeline, so the first draft report was I don't know how aware you are, all of you, about how the legislative process works in detail. So the Commission proposes, and then the Parliament and the Council have to come up with their positions, and then they negotiate to find a compromise. So we are currently in the phase that Council is working on their side. We in the Parliament are working on our side. The first draft report was prepared by me and my colleague in February. Then all the other political groups had time to table amendments up until, I think, 21st of March, and they did that. There were around 2,000 amendments that were proposed, so you can see that this is a relevant and important topic. And now we are currently negotiating to find the Parliament's position. I hope to have the Parliament's position before September, so that in September we can start the negotiations with the Council. And this is very important because you know that next year is the election year, and after 1st of January 2024 everybody will be thinking about getting re-elected. Nobody will be thinking about the EHDS. So this is why we need to have all of this procedure and the political agreement by both the Parliament and the Council by the end of this year. It won't be easy, so in the European Parliament and the European institutions, this is a very ambitious timeline. That it sounds a lot like 7 more months, but trust me, in European institutions this is very ambitious. So I hope we do that. I think that's the only major health file that we'll be able to close before elections. On pharma legislation, it's not our topic today, but I think it's already too late, knowing how it works. I think it will be good to have Parliament's position before elections, but I don't expect that the final agreement will be reached before this term ends. So probably on pharma legislation it will be transferred to the next Commission and the Parliament. But we'll see on that. But with the EHDS, I hope that we are able to close before elections and that we start implementation as soon as possible. So this was all what I wanted to say. I don't know if you have any questions now or.
I have a question for you,
Okay.
if possible.
Yeah.
I actually have two. First, a very practical one.
Yeah.
Of all the health data spaces that the EU could start with, why start with the most complex one at the beginning?
Actually, I think it's a good thing because a lot of things that we resolve now will then be also will not have to deal with them in the future. But I think this is a good thing because I mean the proposal was by the Commission, so they were the ones who decided on that. But I think it's a good thing because actually healthcare was always a marginal topic in the EU. So it was never really a big focus because there were several reasons for that. So one of the reasons that was often used as an excuse was that healthcare is primarily a national competence. And that was easy then for the Commission not to get too much involved in that. And we know that member states, especially some bigger ones, were always reluctant to kind of let EU meddle within their healthcare system too much. This has changed because of the COVID. Partly also because of Europe's beating cancer plan, but and now we have this European Health Union as a concept. So we need to have the political momentum to work more on healthcare. So I think it's a good thing that we start with this now, not to lose this momentum, because after next elections, but already now with inflation, with war in Ukraine, and all of these other things, healthcare is kind of already losing focus. So I think it's a good thing that we started with this. It's a politically important message, I think, for the President of the Commission. I can only speculate, but I think that's one of the reasons, because she introduced this concept of European Health Union, and European Health Data Space was from the start the big, very important part of this. I mean, the most important parts were actually, I would say, four things on the Health Union. So Europe's beating cancer plan that we have, the health data space, the pharma legislation, and the COVID-19 resilience. So creation of new HERA, strengthening of the mandate of the ECDC, and all of these things. So these four pillars are crucial for European Health Union. She made this as a kind of a big political flagship project, let's say, and I think that's one of the reasons why it was important for the Commission also to come up with this as soon as possible.
I understand. You went into the different models of like opt-in, opt-out, consent. If all European citizens by default are delivering their health data, and industry can get that. How do you build a logic for a return to society, a return to patients? You went into that a little bit as some autonomous logic, but what would you say to patients?
So I think the patient groups actually support this. So I think European Patients Forum actually sent a message to the political groups that they support this, because the end result is to get new medicines and to develop new technologies that we couldn't do before, and to do it in Europe instead of the US. I think that's the crucial message. And I think for certain categories of patients, like those who are suffering from rare disease, this is the matter of life and death, really, because these are precisely the areas where we don't have enough data, where we cannot conduct clinical trials, phase 3, because we don't have enough patients to do that. And here, really, health data space can be crucial. So this is the end message. So this is a crucial message. So we prescribed the purposes for which this can be used. We explicitly exclude some things, for instance, using the data for insurance purposes in terms of, determining risks and premiums, things like that. So this is explicitly excluded. So it's only for very prescribed purposes, with a crucial focus on research innovation to create new medical technologies which will actually benefit the patients in the end. I think that's the crucial message. And actually, from the context I heard, we don't have a problem when we speak of stakeholders generally with patient groups. I think most of them realize how beneficial this is, and that we need to facilitate the use of data as much as possible. Those who are mostly attacking us, the NGOs, are not the patient groups, but people who build their I don't know if somebody is here, but let's say people whose work is focused on data protection, privacy protection in general, but not specifically on health, not specifically with patients, but in general about how to prevent the authorities to misuse the data. So the people who build their work around these kinds of things.
Not all of us are citizens. Not all of us are patients yet.
Yeah.
Yes.
Yeah, I mean that's perfectly legitimate, but I'm explaining the logic. Those who will benefit the most from this are really the patients, and I think most of them do not have a problem with this. But as I said, I think the first Commission proposal, which had nothing on that, was flawed. We had to do something. But I think the crucial thing is to really strike a balance. So to give people the right to choose, but also to have the relevant data in the end. I think that's the most important thing. It's always kind of a balancing act between different objectives, different goals that we have, etc. And I think the opt-out really strikes the right balance.
Thank you very much.
You.
We'll have you later in the panel.
Thanks.
Thanks so far. Yes, indeed. Then I hope that the technology works, because one person did not get into the queues on the highway today, and that is Tolias Ianos, working at DG Santé at the European Commission. He is the legal lead on AI and AI liability, and there you are on the screen. Hello, Ianos.
Hello. Thanks a lot. And yes, unfortunately, I couldn't be there and enjoy the fika later that you said.
We'll send you the recipe.
yeah. I got a bit jealous when I heard about the fika.
Yes. You're very welcome. Please, 10-12 minutes as a slot for you to present your perspective on the issues.
Yeah, I will share my screen. I think you should be able to see it, yeah?
It still says has started screen sharing, but I guess it will pop up soon. Not yet. Yeah, there we are.
Yeah, there.
If you now go full screen.
Yeah.
Yes,
it's good.
We see you.
Okay.
The floor is yours, Janos.
Great. Thanks a lot for the interesting conference and discussion on this very topical issue. I would say Tomislav actually quite nicely covered a lot of stuff of my talk too, so I will just summarize or complement some issues. But what he explained, it was quite, I would say, comprehensive on what I would say, but also I will make a little connection between health data and the AI work of the Commission. So starting with the recent, especially digitized, actually abundance of health data, plus the advancements, and especially as we have all seen, very recent advancements on AI, this also creates a great potential to transform healthcare. However, at the same time, and now I'm going back to around 2017 when the Commission started getting into the new Commission was preparing, but also a lot of these discussions started. There were many concerns around AI in healthcare. The first big concern was about the collection, transfer, use, reuse of health data. How do I transfer my data? Actually, even when we started this project on the European health data space, and we carried out several studies, there were a lot of, I would say, even misconceptions or misinterpretations of the GDPR. Some even researchers, member states, hospitals were refusing sometimes to provide data either for research or even to the individual themselves because they were claiming wrongly sometimes of GDPR issues. So there was a lot of diversity as to the understanding of GDPR, especially in healthcare, but also a lot of questions that different stakeholders were facing. And that's why the Commission proceeded with one of the main reasons proceeded with the adoption of the European health data space, which, as you know, it was published in May 2022 and currently at the Parliament and the Council. Another issue which arose with this combination of data and AI, it was a trustworthiness of AI systems in healthcare. Would they be trustable? Would they be not biased and so on? And this is why, or one of the main reasons why the Commission also came up with the AI Act to ensure to give trust to the systems, high risk systems, which includes, for example, AI-based medical devices. And it came out with a proposal in April 2021, the AI Act. Then there were also actually back in 2017, there was a report by the European Parliament when it was carried out a survey, and they found that liability of AI systems was also one of the main concerns of individuals. And hence why the Commission also took that challenge, which was raised by the European Parliament in this resolution back in 2017, and it came up with an amendment of the Products Liability Directive, which was published in September 2022, and an AI Liability Directive, which again was published in September 22, and again, they are at the European Parliament and the Council for discussions. And of course, other concerns which we might have now and within the next 5 years, which are also brainstorming internally within my unit and within SANTE. Now, as Tomislav said, the European health data space is mainly split into two main pillars. Primary use of health data, and as he explained, the idea there is how do you transfer your data for healthcare purposes from one country to the other, from one hospital to the other, and so on. And the other big pillar is the secondary use of health data. And I will dive a bit deeper into the secondary use of health data and combine it a bit with AI to show the connections there. So let's go back to the AI Act. The AI Act, in ensuring the trustworthiness of AI systems, it comes up with several obligations. These obligations, they range from risk management systems to a specific provision on data and data governance, transparency, human oversight, accuracy, robustness, and so on. If we now focus on one of these group of obligations and on a specific provision, Article 10.4, it says that training, validation, and testing data sets shall take into account the geographical, behavioral, functional setting in which the system is intended to be used. So in other words, one of the interpretations that you could imagine there is that if you develop an AI system, for example, in Italy, it could also equally work well in Sweden. So that's, or if you, especially if I push it even further, if there is a very good algorithm which is created in Japan, that it could also work equally well, let's say on skin cancer, it can also work equally well on skins in Europe, for example, if there are differences in how it was trained, validated, and tested with Japanese data, and whether it could also generalize equally well in Europe. So as you can see, there is a very concrete there issue that you would need to acquire data, diverse data from all over Europe, and also enough data to be able to first also fulfill your obligations under the AI Act, but also ensure that the systems we are creating or they are created, they're also fit for the European citizens. And this is where the European health data space could come. And I will use a bit of a cartoonish thing to explain how this could help also ensuring how, let's say, an AI algorithm could be created. So first we have the data subject. I'm giving one scenario. Of course, there could be different scenarios because in the sense that it's not only the patient who is providing data, it could be also other ways that you could, and it's not only the hospital there, but I'm using one scenario just to show a bit, to make a big the story. So we have a data subject who goes to hospital and provides data. Of course, these data now are covered, the legal basis for processing this data are under normal GDPR rules. So this already takes place, there is nothing new there. Now, if the data holder, now the hospital is processing data for certain purposes, which are listed in the EHTS, and they are holding certain types of data, for example, medical images, lab results, and then it creates an obligation on the data holder. The obligation is to give a general description to its data access body. So if you are a hospital in Sweden, then you have a data access body in Sweden. So you give a general description of what data are held within this healthcare facility. In certain cases, there might be also the requirement of giving what we call a data quality utility label, which describes the quality of your data, but I can come back to it later if needed. Then the health data access body in Sweden will create a member state metadata catalog. In other words, you will have a Swedish catalog which will provide a general description of what data exists in Sweden. These metadata catalogs will be sent to the European Commission, which the European Commission will compile an EU-wide metadata catalog. So in other words, you will have now, let's say if it's kidney images for cancer in Sweden, and there is also a lot in Italy, Greece, Romania, then you will create a European metadata catalog on that particular type of image. Then you have the data user. So let's say this is an AI developer and wishes to develop an AI system or to test it to see if it works equally well everywhere in Europe. Then this data user could could check what the metadata catalogs provide, the EU one or the Swedish one or the Italian one. Then they send a data access application to the Swedish data access body if you're in Sweden. Then if you want data from other member states, then this message will be also sent to the rest of the 26 from the Swedish data access body to the rest of the 26 or more, because in federal countries there could be even more than one data access body. This message will be sent to everyone that the data user wishes to obtain data from. Then they will examine your data access application for what purposes you want to use it, if it fulfills the requirements of the EHTS. If so, you will be issued with a data permit plus certain administrative fees that will be required for that one. Then the data now would not be sent back to the lab of the data user, but they will be placed in a secure processing environment, in which case mostly anonymized, in certain maybe special circumstances pseudonymized, but they will be in a secure processing environment. Now the AI user developer could take the algorithm within that secure processing environment, train the algorithm, use the use the data the way they this anonymized data in developing the systems they have. Then if in the process of this development they have clinical significant findings which could be affecting the lives, patients, what was said before, what do you give back to the patients, that could be also an obligation which is created. If you find clinical significant findings, then there is an obligation from the data user to send them back to the health data access body so they will become public, and the patients who provided their data could also see how possibly they could be affected by these clinical results. Also, the data user, if they enrich data, for example, if they carried out annotation processes, labeling processes of this data, they would be also obliged to send them back to the data holder. So as you can see, you're also again helping back what we said about what do you do to help. You are helping back, so this data could be helping others, could help the hospital. They could also get back into the stream. So we're building on the work of each other, and creates a bit this give and take, if you will, situation. Then this data within 6 months will be deleted from the secure processing environment. Then there is an obligation from the data user, the orange things there, to have a public reporting of what they have found. So again, you are providing findings and you are showing a bit how the data have been used, what was the results, and how we're building on this data. And then a few words, I wouldn't say much unless you want me to, because already, as you know, there is of course infrastructures like, for example, the cancer images, infrastructures which are already in existence, or for example, European reference networks on rare diseases, which are cross-border registries there, which are already in existence. So there is, sometimes there was a question, and it is foreseen in the EHDS, how these infrastructures, these existing infrastructures, could get part of the EHDS, or they could be part of this bigger system. Of course, they would still continue to exist, and they will become part of this system. Thank you. That's my end.
Fantastic, Janos. Here, like now we understand the spider web.
Yes.
It was very pedagogical.
Yes.
Something that strikes me when you present this is that there seems to be a reliance on a certain positivist way of looking at data, as if I describe my data in Sweden, it is understandable for somebody in Italy or Romania, and vice versa. We also heard from Tomislav the standardized European health record. To what extent do you believe that we are able to understand and capture when processes are not the same, cultural contexts are not the same across the European Union?
Yes, of course, indeed. That's a question. There, within the European health data space, of course, there is different players who are trying to harmonize, try to have some comparative data. There is some work at different levels on that. But at least at EHDS level, there are some provisions on data quality, which provides certain descriptions of how data could be certain rules, let's say, of which we'll still need to work on and maybe adopt specifications, more technical specifications of how they should be understood. But there's some high level rules there of how data could be described, for example, as of timing, when they're collected. Basically, it's called, there is a section on data quality. And the aim there is maybe it will address some of the issues that you're raising, that it will create more harmony and harmonization as to comparing the data and be able, as a researcher, to be able to see what type of quality of data you want to use and to have some transparency on these types of data. So there is some provisions there, and in combination with other work streams on this, we hope that that could be also addressed within the European health data space.
Interesting. As a second question, for clarification, as a data holder, as a hospital, do you have to make the data available to the national health data access body continuously, or will it be by request?
No, there is, you saw on the diagram, the obligation, at least at the before there is any request for the access to your data, that specific hospital, the obligation would be to give a description of what data you are holding. So let's say we have 1,000 MRI images of lungs on this, on that, and so on. So that would be the minimum description. In certain cases, what I said, they are also to provide some data quality obligations. There is, you may also provide, if you wish, as a data holder, to also provide more information on your data beyond the minimum data description. This is possible. Actually, the law says it may, but it also says it shall give data quality also descriptions if those data you have processed them from EU funds or from member state funds. So if this hospital, let's say, obtain funding to do certain things on the data, then you will have a bit more of extra obligations to provide data descriptions and data quality utility label to the health data access body. But then the obligation would come if there is a request to access your data, that you will work with the health data access body to transfer them to the secure processing environment, to anonymize them, and for the data holder, the data user to access the data, the secure processing environment to work with those data.
Thank you. That clarified a lot. With that, I would like to thank you so much for this super pedagogical presentation. But I would like to invite now Marie-Louise Hennel-Sandström as a more Swedish perspective on this. You are...
Sorry.
Oh, take careful. You're a member of the Swedish Parliament, but you're also a medical doctor.
Yes.
So, Marie-Louise, please.
Okay, thank you very much. I'm very glad to be here. It's very interesting to hear all these presentations. And as Sebastian told, I've been a member of the Parliament in Sweden for 5 years, and before that I was a medical doctor for several years. So I'm very glad that I combine my practice experience now in my mission in the Parliament. So it's very good to do that. In the Parliament, I work in the Education Committee, and I'm working with higher education and research, and it's very interesting work there. I'm very glad to be invited to this conference, and I know that some of you have been to the conference yesterday and the day before, so we know that AA is, everybody's talking about that now in Sweden on the news every time, and I mean, I know also in the world, of course. And I'm very glad to our host, Astra Zeneca, invite us here, and we know that Astra Zeneca is very important for Sweden, West Sweden, and even the whole world with the top quality world-leading research, of course. And we heard that how important it is for the patients, for the treatments, for the research, and also for the research and the business life. And Mr. Peter Blomgren told us how important it is for the research, and we know how much AstraZeneca work with it. And also very interesting to hear Tobias Janos how it all starts and how it now works. And it feels like a dream when it will work that way, because I don't think it really works that now in Sweden. So I'm very sorry to tell that, but it will be better, of course. And we have the ambition to be the #1 in healthcare with life science and precision medicine in the world. And we have some important things that we have to do before we get there. So we see some problems and, of course, lots of solutions. But I'm sorry to tell you, but we still have problems to sharing health data between our 21 regions in Sweden. And we need to improve the patient the cords to talk to each other, because sometimes it doesn't talk to each other. And we heard about it will be better so they can talk to each other all over the world. But now we have problems to talk to each other in Sweden. So sometimes it's easier to send health data to a hospital in Holland than to send from Gothenburg to Stockholm. And that's of course not acceptable, but we will get solutions on that, of course. And we also need more competence and education for this, or of course in techniques, but also in the programs to become a doctor or a nurse. It's not the same way to meet the patient with AA techniques than to meet at the ordinary way that we used to do. So you have to learn about that already in the program, I think, in with education. And Sebastian told us that it's very important with the trust. And when you meet the patient, the trust is everything. It's very, very important. So I have to combine that with the AA techniques and meeting the patients. So I think we have something to do there. And also we have to prove to the patient secretary, so it be sustainable and also powerful, of course. So we have to work about that in some of the laws. And we like to use share the health data and the precision medicine, and how to decrease the perfect way to the patients, to the treatment, and the patient's record. But you have to be more friendly for doctors and nurses to work with it, because the doctors and nurses we work with all day, and we have to work it so we can and when we work with it, and then we can use it for the patients, the treatments, and also for the research, of course. And also we have to increase the work with the law changes, and now even the laws, so we can get rid of the national barriers. We heard that we have barriers in the whole world, but we also have the national barriers. So we have to get rid of them, of course. So now we have the EU standards. We'll work with that, and I'm looking forward to hear what happens with the HDS. Of course, we can be much better. But now we have started in Sweden first, the national standard. That we already had decisions about that, but it's not fixed yet, but it will be in Sweden, of course, and then we will work with the HEDS in Europe, of course. And something very, very, I'm glad to tell you that just 1 month ago, we started a new analysis to have health data in the primary care, and that's where you meet most of the patients, and we want to follow the whole line for when you meet the patient, the first contact, and when you get the medicine. And you have to work it much better. And now we get a registration about that. So I hope we'll make the new law about next year. And I think that the next year we will talk more about this, and then maybe we are in Spain next year, so we can talk about how we will do this and how we'll be making the HDS. So I think I will meet you in Spain in 1 year, and we will talk about this, how much it will be better in Sweden, better in Europe, and the global with the health data. So I think this is one big opening, and we will get many results of this meeting. So thank you.
1 year.
Yes.
1 year. That is very optimistic.
Yes.
You touched upon the primary care part, and being born in the Netherlands and then having moved to Sweden, maybe primary care is not our biggest strength, to put it mildly. What do you see as the education or the training that needs to be in place for this to even make a shift into the ordinary room where a patient meets a doctor? Not in the highly advanced care, but in the regular care. Are there any plans for that?
Yes, there are some plans, and I think we will start with education in the medicine school. We have to talk about that's the new way will you treat patients, meet patients. So I think we will do that first, and then we have to improve the meeting so it will be better for the patients. The patient feel that the patient is in center, even if we use AA techniques. And then we make the meeting, I think we can make more, maybe more quicker and more informative. And the patient can give you some answers before the meeting. And I know that sometimes we use that very much. The patient can follow in maybe some reports before the meeting with the doctor. So it make it more information in the meeting, and the patient feel the patient is in the center of the meeting, and the data for the patient belongs to the patient, but we will also help the medicine care, I think.
Last time I went to a doctor, I got this pile of analog papers to sign to give my consent. Do you see anything happening there? What is your perspective on the need for consent and the way we handle that in a practical way?
Yes, I think we talked a little bit about just before, and I think maybe it should be like every patient say that they want the health data to be used, so it be helpful. So I don't think we have to write so many papers after this. I think that we can use it for the primary, then it is for the patient, but maybe it's for the secondary when you use it for research. Maybe that should be one paper maybe, but not so many.
That would be lovely. Yes.
Yeah.
Thank you so much. You already went into what does it look like in a practical healthcare setting, and with that I would like to move actually to the next speaker who provides the healthcare perspective. So Magnus Kjellberg, you work at Sahlgrenska University Hospital.
Yes, I do.
We got it correct. You do a great deal about information-driven healthcare and AI. Very interesting to hear your perspective on this. The floor is yours.
Yeah, thank you very much. So thank you very much for inviting me. I think this is very good follow-up on the last 2 days we had about AI, sustainable AI and AI for sustainability in general, and our focus on the health area sector. So I was asked to talk about AI in healthcare, and I will do that from my perspective as being head of the AI Competence Center at Sahlgrenska University Hospital. But I will also talk about more kind of on a more national level and focus on the information-driven healthcare project, which is one of the projects that we are doing on the AI Sweden level. So I will start actually with the information-driven healthcare, and suddenly these were blue. I think they were yellow in the. Never mind. So information-driven healthcare is a kind of strategic initiative, and it's what's called an innovation milieu. And Marcus Lingman, who is in the meeting today and also part of the panel from Region Halland, he is the initiator and I think one of the biggest contributors to this initiative. It's all about helping healthcare organizations develop and utilize AI in a much better way. This is a sort of an umbrella project with several sub-projects, which I will come to later. And it's all about being more information-driven, providing personalized healthcare and scalability as well. So currently we are 6 healthcare providers, regions in the project, also 2 academic partners and AI Sweden as the coordinating partner. So we are the core team. We're doing most of the development, but we also have 19 out of 21 regions are in the reference group. So we have a pretty good coverage when it comes to looking at Sweden and how to sort of scale, possibility to scale eventually. So here's some different types of projects that we have been dealing with. It's from the very technical end to the legal end to the barriers towards implementation in healthcare. And you see, it's a number of different types of projects that are connected to the information-driven healthcare or sub-projects within the big program. And one of the most sort of important deliveries from this sort of strategic initiative is to share learnings, and one of the ways to share learning is through this handbook for information-driven healthcare. Unfortunately, it's still in Swedish, and we have no translation into English yet, but it has reached quite a bit when it comes to a national level and being used in several academic courses as well. I think it's a good start if we want to start working with AI in healthcare. This is a good place to start and to understand how to go ahead. So there are a few aspects when you want to implement or work with AI in healthcare, and I will sort of explain a little bit of my personal views here. So, I mean, medical AI, which is of course the focus. How do we use AI for the clinical, our clinical staff or for the patient's benefit, etc. That's really important. I'm really happy that Peter showed so many examples. I can recognize all of them from our settings like pathology, dermatology, radiology, ophthalmology, I think also, electronic health records, etc. And that is of course the core, and it's still a lot of research and development types of projects there, but it's an area where we need to be active. But I don't think we should forget sort of how to operate in hospital and all the kind of other data sources, how the other types of processes that where AI can provide support, planning, scheduling, etc. Another area where I think we need to be active as well is sort of in the AI development and see what type of AI methods do actually work better or worse for healthcare data and in healthcare settings. And also, as we talked, and we will probably talk a lot about, we are handling patient data, sensitive personal information. What type of methods would be suitable, like privacy protecting methods, etc., that could be useful in a healthcare setting. And then finally, and I think also alluding to what Jonas said about the a method or an AI algorithm developed in Italy, would it work in Sweden? And having a way to test this, like a sandbox or test bed where we can test different type of, could be commercially available AI products, but could also be something that we have developed in-house or some we bring from somewhere else. I think these kind of 4 areas I think are very important. I think we need to discuss more about, probably will discuss more about those during the discussions today. So a little bit more about operational AI. I don't think we should forget this because this is, I think we have a low-hanging fruit here when it comes to healthcare and sort of create a more effective administration. We have a lot of administrative burdens in the healthcare sector. So, I mean, one example that we have in Sahlgrenska University Hospital is AI algorithms for predictive number of sick leave staff that are on sick leave. That helps quite a bit for our managers, for different unit managers who have 500 units and have 500 different models to do that. Another example, during the pandemic, we worked together with Ericsson and Telia to predict, using AI, the number of hospital admissions when it comes to COVID-19 patients, and to understand what is the influx of patients, can we plan and can we use our resources in a better way. I think this is all about operational AI, and I think that is an area where we definitely should put more effort because there are quite a bit of low-hanging fruits there. Another area which I think, and I've touched upon this before, is the sort of handling sensitive private personal data. And here's one example where we work together with Region Halland and AI Sweden and others, trying federated machine learning in a project called decentralized AI. So we have problems with the national legislation currently to pool data from different healthcare organizations. So we wanted to create a joint model between Region Halland and Sahlgrenska University Hospital, but our current national legislation do not allow that. So we wanted to see whether federated learning could help. So going from the centralized approach where we pool data and then do the analysis and then do the machine learning, into a federated or decentralized approach where we actually create the machine learning models at each node, at each healthcare provider, and what we actually share and pool are the intrinsics of the machine learning models, the insights. So we are sharing insights and not data in this case. It's a privacy preserving technique, so to say. This works fine. Technically, it worked fine. We did it with different types of data, but all the data were simulated data or open source data. We didn't do it on proper production data from within our hospitals. And then when we wanted to do that, our legal teams got a little bit scared and say, oh, we don't know how to treat it. We are not sure exactly about federated machine learning. How do we interpret our laws against these kind of new technologies? And therefore we were very happy that our Swedish Authority of Privacy Protection had gotten government assignment of supporting innovation. And we became part of we were the first one into this sort of regulatory pilot testbed. And we worked together with the authority and discussed about what are the pros and cons, the legal ones, the technical ones, and got understanding from each other. And a lot of learnings shared. We got an understanding of how our privacy protection authority thinks about these things, and they understood more about how AI works. And in March we got a report and we got some guidance on how to do this. Not the proof of what we could do, but still a guidance on how to interpret the laws around this. Another thing, nowadays it's sort of almost impossible to talk about AI and not touching upon GPT models, and there is a lot of possible use cases in the healthcare sector as well. I mean, it could be everything from digital assistant chatbots, summarizing large amounts of text patient journals, etc. However, I mean, ChatGPT and all these models, they are at the moment based on sort of cloud solutions based in US, tech giants. There are a lot of concerns of using these with our type of processes and data. So therefore, we are really happy that we are part of this project, which is called GPT SWE, or GPT-3 model for Swedish, basically, which is something that has been created as a national effort. It's a national service. We and Region Holland as well are part of the validation project. See how can we actually use this. We know this. Then we know there is also a lack of transparency when it comes to ChatGPT and GPT-4, for instance. We don't know what training data has been used. In this case, GPT-3, we know the exact training data. We know that we know how it has been trained. And the other good thing is that we can also bring this model down within our hospital, within our firewalls, and actually use it without having to send the data outside of the hospital, and we can use it for patient data, for instance. So this is really exciting. I hope this will be. I'm really looking forward to the result from this. And finally, to wrap it up, I mean, we have a lot of things going on. It's still a lot of proof of concepts, but we are moving into the deployment and maintenance phase now. There are a lot of mature things that we could put into, and we need to do that in a structured way. And it's not that easy as one might think. It's like a science by itself to actually do this in a good way. But I think that, it's good that we are coming thus far, and we need to make sure that what we actually put into production is being used in a good way, and that we can sort of monitor it and understand the results from it, and we know that it performs over time, etc. So I think it's really exciting times ahead when it comes to AI in healthcare. So thank you very much.
Thank you, Marcus. Super impressive to see how far you get into real operational working with it. I'm personally very happy that you bring up this operational AI perspective as well, and not just the medical. Sharing a small personal story, it took me 7.5 years to get an operational data set, whereas my neighbor at the university can get a medical data set within a couple of months.
Yeah.
How far do the legislation support you in actually getting this operational data?
I think it depends. I mean, it depends on what type of data. I mean, the operational processes could require different types of data. So if it's like patient data, of course, could take time. It's sensitive. Legislation is really important. In other types of data, it's less difficult. But then you have also the technical problems. We are completely fragmented. We used to be completely fragmented and very difficult from some silos. It's very difficult to get data at all because we don't have the correct technical requirement. We haven't had the technical solutions to export the data. So there are many different reasons why it's difficult to get data. Legal is one, but there are also others. I mean, there's also the culture of sharing data. We don't have that culture in that sense yet, I would say.
7.5 years and I'm still crying.
But you got the data set, right?
We got it.
Whoa,
yes.
Yeah.
Yes. Very proud of that. A fantastic question from online who asks, you've obviously chosen information-driven healthcare instead of a data-driven healthcare perspective. Those can be nuances, but the question is, whose task is it to translate data into information? Is that something where you see that AI will have the task, or is that a human task or a hybrid? How do you think about that?
I definitely think it's a hybrid. I wouldn't I wouldn't say it's not completely human, it's not completely AI. I think AI would eventually be better and better at transforming data into information. And actually I get amazed when I use ChatGPT, and sometimes it's more or less like a human, but I know it isn't, but I think we're slowly getting there, to be honest. I didn't really expect this. I thought a couple of years ago, AI can do very specific, small, defined tasks, not this kind of general, but as the current technology trends has been moving, I need to need to rethink.
One of the things that we need to do is to get coffee.
Yeah.
That helps in thinking as well. Thank you, Magnus. Again, thank you to all the speakers so far. I believe really exciting. We'll be back here starting at 10:55 sharply. For those of you online, look up the recipe for kanelbuller, cinnamon rolls. For those of you here, we have coffee and something. Thank you. And we would like to continue. The second part of our program is mainly contained of two panel discussions. Two panels where we start with the people on stage. The format will be that we asked everyone to prepare a short opening statement. So I'll introduce every person and then ask them for like, what is your position? It will be an open discussion. So for those of you in the room, if you have a question, I have a microphone. Just raise up your hand. And for those of you who are online, you can ask the questions in the same way in the chat as you did this earlier this morning. The other thing is that we have a Slido for those of you online where we have some questions and where you can provide your input on the discussions today. So you're very welcome to do so. We have two panels. The first one will be on beyond the start of the AI EHS legislation. What are articulating the needs, the barriers, the values of it. The second one, already a little bit perspective, will be on implementing the AI Act in a global health context. That being said, welcome panel. A great set of names and different perspectives. I would like to start with Leo Serre Alberich. You work at the Medical Research Institute LAVE, University of Valencia.
Mm-hmm.
Obviously a little bit more of a research perspective. Could
Yes.
you share a little statement with us?
Thank you. Yes, so basically I'm a physicist. I work on research in cancer imaging. And basically I wanted to speak a little bit about the UKAIM project, which as some of you might know is the tool that the European Commission has for building this federated infrastructure of data, cancer imaging data. So basically what we want here to do is to be able to provide an infrastructure that where clinicians, researchers, innovators can go and can actually access the data, can do research with it. There will be like different tools for processing of this data, a marketplace where people can go and retrain models, can actually just execute the models and then annotate the data. At the moment, the biggest challenges are being to try and connect all the different existing repositories that are over there with images that, as you may know, is very challenging, not just because of the nature of the data, but also because images are very heterogeneous. They come from different types of scanners, vendors, centers, protocols, acquisition parameters. So it's very challenging, but we are working on this, and also to be able to do this federated search on the dashboard that we are going to have for the researchers. Is important to have a common data model and in ontologies that so basically all the data can be interoperable and sustainable for the long term. So that's going to be a little bit of my expertise here.
Thank you. It's a challenging task.
Yes.
I know some of our colleagues in Sweden who are in EU came and they speak highly about how difficult it is and interesting. With that, I would like to move to Milana Trutschel. Trying to pronounce correctly. Sorry. Policy Officer at the European Patients Forum. We spoke about patients so far. It's been mentioned very often.
Mm-hmm.
How do you look at this?
Yes. So, well, thank you very much for the invitation, first of all. Maybe just a little introduction if someone is not familiar with European Patients Forum. So we are an umbrella organization. We have around 80 members. They're both national patient organizations, but also European-wide patient organizations. And we are not disease-specific, so we leave the expertise of disease-specific areas to our members. So we work on more issues like patient empowerment, digital health literacy, etc. And in terms of data, AI, EHDS, so we started to work on digital health around 2020 on AI, when the first Commission digital strategy for Europe was published. And before that, around 2016, we actually tried already to see what was the patient's perspective on the data sharing, on electronic health records, for example, and to see what was their position and perception of how this can work and etc. So on all of these surveys and interactions, we try to build our position. So in terms of EHDS, we already heard a few things today, and we can agree on many of those, especially, for example, patient involvement, and especially in the EHDS governance and decision-making structures. We heard already about the consent mechanism. We have a very strong position on that. We agree with the opt-out mechanism, but we also would like to highlight that we are not okay with any type of mechanism of consent if there are no other safeguards. So we really need to focus on data protection, data security. We need to focus on digital health literacy, both patients and healthcare professionals. We need involvement. So there are many things that, so the consent is not the only thing. We need to focus on many important things here.
Thank you. Touches upon many items
Yeah.
already discussed this morning. Marcus Kalliola,
Yes.
from Finland today. You work at TEDAS. You've been involved in, well, may we say, a little bit of a precursor towards the EHDS. Where do you see the value? Where do you see the barriers at the moment?
Well, maybe firstly a couple of words where I'm coming from, so you can put my words into the context. So I've been working with the health data approximately the last 10 years, first in the European Commission, then in the Finnish Innovation Fund for Finland mainly. And in Finland we established the secondary use of health data legislation in 2019, in which the Finnish Innovation Fund, so my organizations, did a lot of the background work. So we thought how this could work, how could we enhance the use of health data in Finland. And we financed a lot of the basic operations in university hospitals, for example, data lakes, building up those, putting the metadata available, making the safe environments for using data. And then we established an organization called FinData, which gives the permissions in Finland for the health data use. So a lot of this work was then used by the European Commission to plan the secondary use of health data in the ESDS legislation. And mostly of this, because of these experiences in Finland, the Finnish Innovation Fund also is currently coordinating the joint action towards European health data space, which is a project funded by the European Union, which has 25 member states involved, including Sweden. And from Sweden is the Swedish e-health agency, which is the competent authority in that joint action. So we give recommendations for the member state and the Commission in how to plan and build the European health data space. So regarding the barriers and the possibilities, we made a study actually on that in the TEHDAS joint action. We started interviewed specialists and studied scientific papers, and we found more than approximately 100 main causes of the barriers, and we grouped those into categories. And out of those categories, we categorized 11 main categories. 6 out of those were legal based, so legal problems, different interpretation of GDPR issues, were the 6 categories out of 11. 3 were semantic, which was also mentioned today, so we don't understand each other's data. 1 was technical and one was trust-based. Many times we think that the technology is the problem. We don't have the tools to transfer the data, but actually it's the legal uncertainty, and this is where the ESDS come into place and can solve a lot of these problems.
Thank you. And you already mentioned the e-Hälsomyndigheten, the e-health authority in Sweden, as the one involved. And Annemieke Olenius, you are working at the e-health administration.
Yes.
Could you share your view?
Annemiek Lenius. I'm one of the deputy directors at the Swedish e-health agency, and I'm also a national commissioner concerning a large national inquiry on health data as a national interest. This inquiry is aiming at improving the possibility of interoperability of data within Sweden. But what I would like to state here, that's the importance of trust. The Nordic countries, they have a very long tradition of sharing data, of collecting data of its inhabitants, and this is based very much on trust in governmental agencies, but also the Swedish population is very positive to the benefits of science. So it wants to contribute very much to the development of science and the development of the governmental work. But at the same time, Sweden has been able, and the Nordic countries, we have been able to share and collect this data, and keeping also the integrity of the individuals. This is very common in the Nordic countries. I was also involved in the COVID certificate project, the digital COVID certificate, and we were very much discussing within the EU about the data set, the amount of data which should be in data set. And then I noticed very much the different kind of views from different parts of Europe, because it was there was a large temptation in trying to collect as much data as possible, while we in the Nordic countries very much were driving the discussions about a minimum data set. We should strive for having as little data as possible which is necessary, and not collecting data which could be nice to have. I think that's very important, because if we lose the trust of our populations in giving their data or sharing their data, then we get a bias, and then we get problems with the representation. Well, I can say more things about that. There are different cultural values, but we'll have a discussion later on also.
Thank you. Tomislav,
Again.
again, you had your 25 minutes, so I think your position is rather clear. But if you listen to the points raised here, how do you manage from your perspective the diversity over Europe, both on the legal and the
Yeah, I think on the data minimization principle we agree, and that's something that we try to strengthen in the first draft report. We added the specific provisions that this should be only be data which is necessary to be used, so not just any data that might be interesting. So I think that definitely on that point we try to, in the first draft report, to really strengthen that part. So the rules on the data protection, on which data can be used, etc. And we agree. I agree with what was said before, and also by the European Patients Forum, that it's not just about opt-out and opt-in. It's also about how to make sure that we only use data for the let's say public interest purposes, which is the whole point. So research, innovation, developing new technologies, etc., and helping the patients in the end, and how to have all of these safeguards provided. So I think that we've done a lot in the first draft report to strengthen these safeguards additionally, legally, of course. We cannot do it technically, but we can provide the legal framework so that that this protection is strengthened. And I also agree on the literacy. I think it will be important to spread the awareness of this whole issue to the patients, but also to medical professionals. And I expect that there might be some opposition there, especially with let's say more experienced part of this population of medical professionals who are used to doing things in one way. Now this will be a big change when this whole thing kicks off. So this is why we will ask for longer implementation period as well than what Commission proposed, but still not to expand it to 10 years or something. To try to have this kind of reasonable 3, 4, or 5 years, which will then be necessary so that all the stakeholders really are informed about what is going on. And also one thing that we also provided is to have a special additional implementation period also for individual medical professionals, for instance in primary care. because in many countries, like in my country, primary care providers are actually private individual ordinations or some private individual practices who already have a lot of administration, a lot of bureaucratic work that they have to work on, and the idea is not to overburden them at the very beginning with all of these additional obligations that they will have to take care of. So to also give them these additional possibilities so that they can that they have a bit more time to adapt to this whole system. But definitely raising awareness, investing into literacy is important. We also added in the first draft report the provisions that member states should also invest into programs of training of all the stakeholders, especially medical professionals, and raising awareness. So definitely, so that this implementation goes as smooth as possible. But we will also, I think, need to have additional probably funding and help also from the European level that this is achieved.
Can imagine. Now you work on an EU-funded project on a part of health data that might be the most standardized, namely images.
Yes.
How practical do you see that this gets implemented? Does it work?
It's challenging because certain points, probably one of them, maybe the first one, is about legal, ethical issues that we have been facing. Because we have, I mean, I work more on the AI side, but we have these questions always from the legal teams asking, like, have you performed a risk analysis on if your anonymized or pseudonymized data can be identified again in your repository? And this is something, for example, we wanted to have like an open challenge in, like, okay, we put there some images that have been anonymized. Can anyone in the world be able to identify which patient this data, this image belongs to? And if that's the case, that would be, you know, a strong argument for actually checking our regulations or checking how we are actually identifying patients at the moment. So this is one of the topics that we are facing and a challenge. But then on the technical side is certainly how we manage to, first of all, be able to harmonize and standardize all the image data and the clinical associated data to these images that are in the different hospitals in Europe. Do we go hospital by hospital, creating this net where they may or may not comply with the technical requirements that are needed for having this federated infrastructure? And in the case that it's not possible, can these hospitals be able to provide the data into the central repository, forming this atlas of cancer images? So there's several challenges that we are facing hospital by hospital, and probably this is one of these events that is very nice for us because we started the project with 21 clinical centers, but we are aiming to have probably about 40 or more at the end of the project, at least. So it would be very interesting that also clinical centers who are willing to participate in these sort of initiatives and are hearing from here also get in contact with us, and we have a team that actually helps to incorporate this data that they may have in their hospitals into the net, either in a federated way or in basically in a centralized way. So, yeah.
That touches upon the support structures that need to be in place. And,
Yes.
and Annemieke, if you think from the e-health agency, what initiatives are you taking at the national level to actually provide these support structures?
Well, we are discussing very much about this interoperability issue, trying to get more standardized data. So we have had some inquiries about how to be able to implement the secured processing environments, for example. My colleague who's making a photograph there, he has been responsible for that. But we also have looked upon how we can improve the conditions for the quality registers we have in Sweden. We have a large amount of quality registers, how they can be combined so we can get some more information. But I think the interoperability issue is very important, but also what we heard about from our colleague Magnus here before, the large language developments, because we have a lot of historical data if we start to standardize and structurize, then we can get information from now and onwards. But if we have techniques which we could use for having the historical data, then we can, if we put AI algorithms on them, we can get a lot of information which we do not have today. So I think interoperability, standardization, developing techniques is important. And at the same time working on digital literacy, because we should one very, very essential point is not losing the trust of our citizens. And I want to say something more about that, because when we're talking about healthcare data, health data, we're very often talking about data from healthcare institutions, data holders. Until now, a lot of data has been collected at hospitals, at primary care, and so forth. But in the future, the large amounts of data won't be collected there. They will be collected outside. And if those actors are not using their data or not protecting the data in a proper way, this would also harm the system, the system of the healthcare collected by all the institutions. So that's why I think it's very important that we start talking about certification of certain devices and apps, so that the user, a normal citizen, can see that this app is certain, is secure to use, also from an integrity perspective. And
you bring up the perspective here of patient-generated data as well.
Yes, exactly.
The patient nowadays is controlling his or her own self. How do you look at that, Ilana?
So on the just to come back on the issue of trust,
Please.
I think that's very, very important. And if we do not try to work on this, then we might even create even more healthcare hesitancy, which is then we won't have the data, because patients don't trust the healthcare professional, would not want to go because they know that the data is maybe not shared in a proper way, or not protected, or shared for purposes that they do not support. And I think that this can be done on one side with patient involvement, because if they're involved from the beginning, they can also have a say. But also, the more you know about something, the less you're afraid, the more you trust the system. And so I think there is a lot to do on that. And one other thing that it could be very useful is sharing the best practices. It's really showing to the patient what what worked well, and how this data has been protected, how this data has been used for maybe something that in the end created a value for the patient, how it improved their life or their disease management, or not just the patient themselves, but also the whole community, because patients usually do not share the data for themselves. It's really about other people who might have the same disease, or if my data can help some other diseases, the creation of new medicines, medications, devices, etc. And also, if I can just mention on the digital health literacy, I think that's indeed a very, very important point, but maybe the focus should not always be on the patient. Digital health literacy is not really about patient learning things. It's really about how these things are explained to the patient, how they're presented. So having a good level of digital health literacy is actually trying to see how many different levels there are, and try to reach to this patient in different ways. So there is the lay language there. Because we don't, even very highly educated people, they sometimes cannot really, understand some of the most important issues that comes with health data. So it's really, it's not really just the patient. It's really about how the systems deals with different levels of literacy.
Very good point. I would like to go to a question in the room.
Okay. This question is really for whoever wants to take it. So just thinking about perspective as pharmaceutical organization who's very much used to reporting clinical trials, reporting and sharing data across a number of different venues. We find sometimes we have to navigate some conflicting advice either between local countries and larger governments, or between legislations themselves. Wanted to know what your thoughts were on trying to find harmonization across different legislations and between country level and region level or European level. Again, for anyone.
Who dares?
Yes, I think this is the key topic, and this was one of our findings from the Data Joint Action. What Leonor was saying in earlier, she said that when they started the project and looking at these images, the first thing they did is where they went to the legal team and ethical team and how to pseudonymize and that. We held a project forum in Tehran. We had more than 50 European projects, nearly 100 participants, and we asked the question who have had legal uncertainty on their project, and each one of them said that in the beginning of the project they went all these legal things and they went to see which in your country how you manage the data and how it's done in another country. And I flew here today by airplane. Now it's quite efficient. You buy the ticket and you fly. We don't sit there before the flight for many hours and discussing about ethical problems that there might arise during the plane, or what if somebody gets sick in the plane, do we land in the Stockholm in the middle or not, or what do we do? So we have guidelines, we have processes, and this is what we need also for health research in Europe. We need to have guidance of how the pseudonymization and anonymization is done. Not every project needs to think it again on their side. So this is something that the ESDS should provide us, a really baseline for how things are done, how decisions are made, who makes the decisions, how the data is being collected, how it's anonymized, how it's used. And we need to move from this project-based into operations in research. Because otherwise, all projects, when they begin, they waste their time on these things and they solve the questions individually. And I think this goes for the pharmaceuticals as well. You need good guidance and you need clear rules in Europe. Otherwise, we lose the research to other continents that do this more efficiently.
But you raise a important point here in the parallel with flying, because what happened was that you went on an aircraft, but going on an aircraft has become more normal. Whether we now, in terms of sustainability issues, know that, for instance, my organization doesn't allow me to take an airplane to Gothenburg because there's a train. So the unintended consequences of those rules, do we know sufficiently already to be able to put those legislations or those guidelines in place, or where do you see that we need to explore together?
Well, in Finland we established the FIN data. They have made since 2019 more than 800 decisions on different research projects based on exactly the same guidance. So whenever they have a new project, of course they look at the research plan, but they evaluate it based on the legislation. Is this research plan based on the grounds that they can request the data? Is the minimization principle according to the plan? Do they request too much data, or do they request the right amount, and so on? So they assess based on the criteria that has been already set. So I think it's very robust and it works.
Good to hear. Annemieke, you wanted to respond?
No, I just wanted to stress also the importance of having organizations which on a national or a European level work with the interpretation of the rules, because that's not a static issue. It is a matter of development, maturity, and the interpretation of the rules in the beginning are maybe not the same that will be done in 5 years when the technical development has been ongoing, but also the societal development. So I think we have I know that Norway has a Norman, you have your organization. I think we should have also more cooperation on the European level, how we interpret it, the different rules, because that's what you say, even if we do it on a national level, we have to lift it to a European level. And it is not static. The interpretation that is given now will not be the same in about 3 or 4 years from now.
I hope so, because then we developed.
Yeah.
A question here. Robin.
Thank you. Can I come back to the issue of historical data that was raised just now? And actually, the speaker from DG Santé mentioned the challenge of incorporating, for example, disease registries in the whole system of the European health data space. Yet, the European Parliament is kind of discussing well, opt-out or opt-in mechanisms, but how is that going to apply to historical data? In many cases, we can't go back to those people from many years ago, whether that's disease registries or long-term, large epidemiological cohorts. And actually, Europe is very strong in that kind of epidemiology research, Sweden and elsewhere. Do we risk losing the value of that because we can't go back to re-consent or re-ask the patients whether they want to opt in or opt out for new research?
I want to comment on that because, for example, I think in the majority of the projects that have been funded by the European Commission, what we are doing is to try to leverage all those data. So we are actually taking advantage of those historical data that are in the different hospital silos, and with the AI, the power that it has is that now many types of algorithms can actually extract the data that is in different formats and probably even not collected in a structured way. So I think it is actually what we are trying to do, to try to recover this information. Not only that, but for example, in the UKAIM project, one of the topics is going to be to use the data from screening programs. So this is also a huge amount of data that, for instance, for example, breast cancer in screenings, like so many women, since they are 40, they take regularly these images, and probably they are fine, but is there anything in that image that could predict before a radiologist, someone with their own eyes, could actually detect a tumor that could tell you that in some years you could develop actually a disease? So this is and this is actually something that is happening right now. So I think for all that amount of data that is already acquired and it's in the hospitals, etc., it is or aim, or I think it's mandatory to recover this data and to use this data for research. We cannot really discard it. And then for the future, for once these infrastructures are in place, I think one of the potential solutions is to incorporate the patients, and all my colleagues were saying here, to try and make them know from the beginning what is their data, what we're going to do with it, what other patients are benefiting from this, and then from the get-go, from when they start to go into a clinical practice, they give their consent to be able to use the data for secondary use. I think that would be, well, my approach on this.
Do you agree with that from a patient perspective, or?
Yeah, I think we cannot go back, and there are people who simply you cannot, especially if they were anonymized, you cannot come back to the data that has been used already. But we can build something new from now on. So, yeah, and also the purpose is that EHDS opens to in terms of the data we use. It's much bigger than what it is now. So we have much, more need for consent. I mean, for at least giving the patients the opportunity to object if they do not want to share those data.
And for you, Tomislav, historic data?
Yes, I mean the regulation definitely applies pro futuro. So it applies for the data that will be gathered. So I think that's the general principle, general idea. But of course, about historic data, how if there are some exceptional circumstances in this, it can be used, and in what way, that's something that should be, I think, decided in very on separate occasion, but in very specific circumstances, if there is some kind of a public interest need, etc. But as I said, I mean, when we speak about the EHDS in general, of course, it cannot apply for the past. It applies in the future.
Yeah. I would like to throw in a new component into it. If you look at the World Health Organization's definition of health, it is a state of well-being in the social, physical, and space. Much of what we discuss is about treating diseases. Where do you think the boundaries go? Because, for instance, in Sweden, it's not just that we have 21 regions that deliver healthcare. We have 291 municipalities also delivering health healthcare, social care that is related. Do we capture that, or do we ignore that for now? Where's your position?
Now, I think you have a very important point there, because we're talking very much about prediction, prevention, trying to get that people do not get sick, or they get sick later on, and so on. And in order to, we also know at the same time that for children, for example, the development of their health status is very dependent on the socio-economic conditions they are growing up into. And I think it's very important that we start to broaden the definition of what is healthcare. Healthcare is social care as well. I mean, how the conditions are before. If you have had any problems, if you have had any contacts with social care, will often, very often, it also has implications on your health in the future. So I think it's a very good issue you make there, that we should start to broaden the scope of collecting data.
Yeah, it's a very good point, and I think that this is also where the AI is very promising. Unfortunately, for example, in Finland, at the moment we cannot use the AI, for example, for preventing diseases, because the healthcare cannot contact the healthy citizens and saying that you might be sick in 3 months or in a year's time. You should change your behaviors or something like that. The patients need to go to the doctors to request for the treatment. The same goes for what you said, well, regarding the social services. We had a trial in one of the cities in Finland for using AI to find signals on the child welfare, and they could find a lot of signals, for example, from school or elsewhere, when the child welfare services is needed 6 months from that, and then the situation in the family has already escalated. But even that project they had to close down because of the privacy protection reasons, and the social welfare services cannot contact a family before the problems arise. So I think this is where we could really focus much more in the future.
But then are we talking about 1984 Orwell type of monitoring society, or where are we? I find it difficult.
It's not easy, definitely. Otherwise, it would have been done already.
I want to comment on this in particular, because when we are talking about how much data should we use when we want to develop some models, some AI models that actually are going to be useful, robust, universal. So what is the data set that is gonna make this possible? Is it just from the main hospitals in Europe? Is it from smaller centers that might have some rare cases that are not incorporated into the building of these models, and then the model is not going to be generalizable enough? So I think for this is going to be needed some monitoring of all the solutions that we are developing, and this has to be in place continuously in an iterative way in time. So we have seen with COVID, like the type of diseases changes with time, and we have to incorporate the new data that comes into the hospitals, into the development of these models. So it's very important now with the new technologies that allow to produce these continuous learning approaches. So basically that we do not have static models that start and end in a particular point in time, but we have models that keep developing in time and never stop. It's just, you just keep learning as if you are also learning when you are just a doctor and keep learning about a disease. You never stop. It's the same for the models. They cannot really be static and then we forget about it. So from the data, it needs to be the same. All the data that keeps being is incorporated right now in the hospitals day by day need to be incorporated in some system through these models that keep being retrained, and then we can have updated estimations that are real for the population right now.
And that to a certain extent conflicts with the certification of an AI application, the security.
Yeah, probably rules for how we benchmark these models will need to be there in place. Of course, the AI is developing at a much faster pace than probably regulations are being there, which is, yeah, like we are seeing, yeah, some countries banning ChatGPT, things like this, because the regulations and ethical concerns, we cannot keep up with them probably right now. So it's an ethical problem at the same time, but it's here right now, and we cannot really avoid or looking at another side, right?
Then I would like to go to you, Tomislav. If you have a theory about the growth of Europe, and you think about not only the pharmaceutical industry, for instance, but also the Googles, Apples, Amazons of this world obtaining massive amounts of data about us. Where do you see the balance? Because a lot of this data says something about our health. And to a certain extent, what I observe that we discuss is the use of more clinical data for clinical decision making. Where do you put those boundaries, and what is your vision on how Europe will be competitive? Because we constrain these companies much more than, for instance, in the US or China.
Yes, I mean, what is important is first that we clearly define the purposes for which data can be used when we speak about the HDS, but also the purposes for which data cannot be used. This will be one of the very important parts of negotiations. I think what we already have in the report and in the proposal is, for instance, that it cannot be used to determine premiums, as I said, making decisions about insurance contracts, so things like that. Maybe something else can be added. Maybe something more precise can be added. We'll see. I mean, I'm open to this possibility because yes, we have to be competitive, but the health data space primary focus is on providing healthcare and research innovation for new medical technologies, specifically to provide healthcare to help patients. So we should definitely, I think that was our position from the start, that the definition of purposes for which data can be used should be really limited to that. When we speak about the big tech giants, of course, it's a separate topic. Goes broader than this, but I'm glad that we enacted DSA and the DMA in the European Parliament, so and in the European Union in general. So the Digital Services Act, Digital Markets Act, which already set clear boundaries to what they can do. Of course, these boundaries are stronger, for instance, than the US, but I personally know from the contacts I had with the US administration that actually they are studying what we have in DSA and DMA, especially DMA. That's the kind of a more antitrust competition law point of view with the blacklist, etc. They would like to copy it, but it's very hard for them in the US because of it will be very hard for them to pass on the new legislative framework, and also they have the problem, I think, with their courts, which make it very hard to implement some of these limitations that maybe they would like to. So it remains to be seen what will be in the US, but I know that this type of EU regulation is something that many see as a role model, and they would like to implement it also elsewhere. In general, it is true that our standards, for instance, of data protection, of privacy protection, in Europe are the highest ones. And of course, if you look at that, of course, in some other countries like China, for instance, where these standards are not so high, to put it mildly, of course, that when we compare to them, this creates a competitive advantage for them in some areas. But I think this is also part of the European way of life. This is something that Europe is specific on. I mean, having all of these standards protection, not just thinking about one purpose, but trying to balance all of these different purposes and principles, etc. And I think that Europe should definitely stick to this. But of course, we should try when we have, for instance, negotiations on trade agreements, on reciprocity, on within the WTO and in other areas, we should try to also think of not imposing, but saying that if you want to trade with us, if you want to have access to European market, if you have to have all of these freedoms which European law entails also for you, then you should also try to think about imposing some of these standards also on your territory. And when you speak concretely about health data space, for instance, and the possibility, that's also one topic that I didn't mention, but it keeps coming up about the access from third countries to data.
Yes.
This is something that the Parliament really wants to be very strict. So our position is that we don't want this data to be stored outside of Europe. That's a very important thing. And also, if somebody else from the third countries wants to access European data, they should definitely. So the Commission should at least make sure that their standards of protection are on a similar level as in Europe. I mean, it's very hard to say same level, obviously, because you can never just copy the same rules. But the standards, the level of protection should be on the similar standard as in Europe, so that I think this should be really a condition, that because if we don't do that, if we do not prescribe something like this, we shoot ourselves in the foot. So I think this is very important, because a lot of other players who want to access the European market, European data, etc. Yes. So if they want to do this, there has to be some kind of a reciprocity.
I understand. Now, reciprocity, we continuously assume human data, but there's an online question, and that is, do we actually consider animal health data in this as well? And to what extent? And I think, given the zoonosis and possible transmission, how do you think about that?
Yeah, I mean, it's a very good question. I think the definitions that we have in the regulation itself can be interpreted very broadly. So this is something that may be included on that. But this is something that I think we can think about. So in what way should this be regulated? I think it's a very good question, and maybe we should put some more precise provisions in the final compromise itself on that.
Follow up on that. Is there any kind of priority on what data scope to go with first? So that could be a build on the animal versus others.
Yeah, I mean the data. I mean, when we speak about secondary use of data, as was already said, I mean we have the obligation of reporting. So of course this depends on on institutions who do that. These are hospitals, for instance. But of course the prioritization in the end of which data will be used will depend on those who request data, who want to have access to data. So they will request data from health data access bodies. So I think that will determine what will be the priorities. So what is needed, let's say, or what is requested.
Good.
Now, regarding the question of non-personal data like animal health or environmental data or others, I don't personally see a problem there. The European health data space builds on top of the GDPR. So it's basically the scope is the personal data. We don't need, in my opinion, to put other data in this legal file. It doesn't stop us from using that data together with the personal data. But the personal data, the health data, is then what determines the security standards, need to be in a secure environment and so on. Now, if you add other data into that research, including you want to research asthma with the environmental pollution data or something like that, it doesn't prevent it. You just put it into the safe environment, but you cannot use then the environment that you usually use for researching the climate data and others and put the health data there if it's not under the similar secure requirements and under the same surveillance as the health data. So it needs to be determined by the European Health Data Space Regulation how the health data is managed, and then you bring the other data into it.
But I agree, of course. But I think in general we have the situation of and that's one of the big technical parts in the first part of regulation, is this relationship between the HDS and GDPR and other types of regulations. So how does this work in practice? And I think, for instance, if you have one data set which maybe combines several aspects which go maybe a bit broader than health, this is something that maybe could be regulated more specifically, how you act in such a concrete situation. But of course, I mean, we already, of course, have the other rules which are applicable to non-health data as well. Yeah.
I would like to end this panel with the patients, to put you central. Where do you hope that we are in 3 years?
Well, first of all, I hope that we'll agree on HTS, because I know that we're hoping to do it before the elections, but seeing where the council is at the moment, I'm not sure that's going to happen. And if we have the new MEPs and, you know, if something gets redrafted, then I hope at least we'll have the regulation itself. I know it takes more time for the implementation, so I cannot really, I don't have the expertise on that, so I cannot comment on where, but I think that I hope that, so now we never talked more about digital health than last year and this year. And I hope this is going to continue, but I also hope that this means also involving the patients more. And we are here, so we are speaking on behalf of patients, we're being involved, but I think it's a kind of a message to all stakeholders, especially those in power, so regulatory power, commercial power, innovators, researchers, involve the patients as much as possible. We can provide very important feedback and add actually to anything that's being done now in digital health.
Thank you so much.
Thank you.
I think we should give a round of applause to the panel. Now we're going to switch to a second panel. Can I ask Annemieke, maybe we can chat a little bit while the technique is putting the headsets on the 4 next panelists over there. If you could come here, we can talk a little bit. Both you and I are Dutch citizens immigrated to Sweden, which means that we to a certain extent have experienced the different views that you can have on healthcare, on privacy. What are your experiences here that influence the policy work that you do?
What strikes me most is the differences between Sweden and the Netherlands concerning primary care. In the Netherlands, you have your own doctor for many years. You're building up a relation. It's not only a medical relation; it's a social relation as well. And they have a more holistic perspective where you have the whole family. It's not for nothing, which I said to you, that it's called a house doctor. Yeah. I mean, it's a doctor for those who live in the house together. But also, on the other hand, it is a very good thing in Sweden there where we have access to specialized care if we want to. We have this possibility of using the personal identification number and collect the information. So both systems have advantages and disadvantages. Mm.
I can imagine that. Mm. Now, Marcus Kalliola often raised how important it has been for Finland, how far they have come. Mm. You're more or less responsible in Sweden to push the boundaries. Where should we put our priorities right now?
I think we should put our priorities very much on increasing, first of all, knowledge, which is very important, which is done here. I think we have to work more with our population to explain the advantages and this what we're talking about, the artificial intelligence, but we also have to start standardizing our data more, because that will enable us to achieve more information and get more knowledge, even if we have this large language systems which can solve a lot of problems, but I think it will go faster if we start standardizing, and that is what we are prioritizing.
And standards are complex.
yeah, they're complex. They're working very well on other areas, so why not here?
Yeah, yeah, absolutely. I'm looking at how far we are with headsets. Still working on that. Robin, I see you already. Thank you, Annemieke.
Yeah, thanks.
So, and Margie. So, please have a seat. Maybe you can be. Well, Robin, already by the name, you have a UK accent. You speak proper English with us, just imitating. Maybe we are the chat GPT of language pronunciation?
Maybe I'm taking a European as well, of course. That's with some embarrassment.
Yes.
Yeah.
Maybe, Mark, if you could sit there, and Marcus, place number 4 here. Then we're waiting for Magnus. If we start with you, Robin,
Yeah, sure.
while the others are joining.
Sure.
You are the Biosciences Program Director at EASAC, the European
Yeah.
Academy Science
Yeah.
Advisory Council.
Yeah, yeah.
That sounds splendid. Maybe you could explain a little bit
Yeah,
about what you do,
okay.
and also your
Yeah.
perspective on this
Right.
AI Act.
All right, I'll try and explain briefly. Essentially, ESAC, European Academies Science Advisory Council, is an umbrella group for all of the national academies of science across the European Union, and it's kind of a counterpart of FEAM, who are one of the co-organisers, who are the umbrella group for academies of medicine. So, and of course, some academies fall into both groups, but essentially, ESAC and FEAM have worked closely together on a number of issues, and very recently, in the context of this meeting, has started a new project on AI in healthcare. And we recently completed a scoping paper as a start of this new project. So actually many of the issues that we've been talking about this morning will come up during the course of the next year in this joint academies project. I just want to make two points, I think, in time available here. Actually, coming back to your welcome comments and the title of the meeting, Sustainability and Global. And in terms of sustainability, the AI Act is the first international legislation in this area, and of course both in the EU and globally we want it to be coherent with the various legislation that's already available, Medicines Directive or whatever. But in the context of sustainability, one challenge is really for the net zero society in Europe, major priority for the EU and of course many other countries. And within that net zero society, the healthcare sector has a leadership responsibility for its own sector to decarbonise as far as possible while maintaining the quality of healthcare, of course. And while a lot of those actions for decarbonising healthcare facilities and the supply chain are indeed responsibility of a member state, that there is and there are things that the European Union can do to facilitate those efforts by the sector itself. So that's one policy issue that hasn't really come up, but in European Union terms of the Green Deal and so on, that is a big issue for AI, digital health and the sector. And the second point is global. And yeah, of course, the value of AI depends on the quality of the data and our ability to share data, federate data, understand heterogeneity and so on, as discussed this morning. While, of course, respecting privacy and trust issues. However, the value is global. And one of the points that came up late in the last panel was the issue of access by third countries to EU data and vice versa. This has become an increasing problem in consequence of the implementation of the GDPR, I'm afraid to say. FEAM and others during the drafting of the GDPR worked hard to ensure that research was allocated a special position within the sharing of data under the GDPR. However, it's become obvious in the last couple of years that essentially there are new impediments for sharing data with third countries. Actually, of course, includes the UK now as well.
I wasn't going to mention Brexit.
And I mean, the UK now has an adequacy decision, but I don't know how long it will manage to keep that. But anyway, leaving aside the UK, it's not just a question of, I think feeling how third countries can capitalise on EU data, because actually EU and EU patients can capitalise on data internationally. For example, in considering the response to various diseases, to various interventions, we need to know about variability between different cohorts, different populations worldwide. And we need, in Europe, access to data from the rest of the world to understand those determinants of patient response. So value is global. The problem of sharing data, and I'm talking about the public sector, I recognise, of course, there are private sector issues that continue, but actually that was one of the problems, that politically the private sector has dominated those discussions of global sharing at the European Court of Justice and so on, and the public sector has been overlooked. Well, so that's a problem. FEAM and ESAC have published on this already, and I can point you to those publications. My point is that it may well impede the development of new AI for healthcare, because we can't share research data globally to develop the AI. Thank you.
Thank you. Now we switch to another accent, because we have an American as well. Margie Chef, you work for Astra Zeneca.
Yes.
A little side note, she's also the one that put almost all the efforts in the back of producing this great event. So a little applause.
Thank you.
But now you are here as actual specialist, AI specialist. You obviously have an industry perspective. If we contrast that to what Robin provided.
Yes, thank you. So I work to implement our company's AI principles. I believe Petter shared them earlier. Apply those principles in practice in the way we work within our pharmaceutical organization to protect our values while using data and AI. One of our biggest goals is to ensure that human and machine work together with values and trust building at the core of what we do as we drive Sustainable Development Goal from the UN number 3 on access to health. Part of this is understanding and interpreting what the AI Act means for us and the biomedical industry, and as private sector and as multinational corporation also, because we use, store, develop, deploy data and AI for global benefit. And we need to focus on equitable benefits of our digital solutions, our AI, our technologies globally, in all the countries that we provide access to care to as one of our own company sustainability pillars. So part of our realities is understanding how this works, not just within Europe, but as Europe as a global player, and a large network of different regulations that are coexisting, how to navigate them in order to be the most equitable provider of healthcare that we possibly can. For that, AstraZeneca is very grateful for something like the AI Act, because that helps us build confidence and trust in using AI and digital solutions in our work, and bring us comfort and confidence to the scientists and the entire spectrum from bench to bedside, as we call it, bringing access to care using AI and digital technologies.
Thanks. Then we move a bit more to the reality of what a region in Sweden works with. Marcus Lingman, you work for Region Holland.
That's right. As a clinician and in the senior management, we're really looking forward to the AI Act coming into action, actually, because we need the capital of trust in using AI in healthcare. Healthcare, we're really used to handle sensitive data. We're really used to handle risk. So in that sense, artificial intelligence is not a total novelty to us, but it is to the public. So when we say that we are using artificial intelligence to guide the treatment of you, sometimes we're met by skepticism and even distrust sometimes. So we really need a regulatory framework that solidifies trust in the models that we need. But I must add that I don't think that AI Act is the complete solution for that, because we already have a number of frameworks in place to safeguard integrity and the technical side of it as well, including the medical device regulations and hopefully also the European health data space coming up, even though we know now that the secondary use purposes for healthcare data will be difficult, not least on the political level. So maybe the AI Act will not alter the way we use artificial intelligence in healthcare in any drastic way, but hopefully it will build a good foundation for public trust in the models that we try to do and develop in a scientific way already now.
And that is spoken as a healthcare organization that develops these models themselves as well.
We develop them, and we use models developed elsewhere as well.
Cool. Magnus, we've seen you, but not heard you about the relation with the AI Act. Where do you see the biggest value coming up?
Yeah, I mean, I think this whole conference today and yesterday is sort of very much in a timely manner, because the sort of a year ago I was sort of preparing myself mentally for like an AI winter or something, because it felt like we had put a lot of effort into into AI, and AI didn't really show the value. But like the last 6 months or so, I think it's sort of just exploded. So I think this is really good that we have this conference now. We are totally benefiting from it. And when it comes to the AI Act, I think I would see AI Act and all the other legislation as opportunities for us to reset to some extent. I mean, we have national legislation, we have other legislations that we feel we are not really comfortable with them. They are difficult to handle. This is an opportunity for us to perhaps start over understanding how to move, how we should create them in a way that it would work and benefit us in a better way. And on that side, I think it's also good that we not just talk as we do today, but we also start doing things, because unless you start doing and really understand how these sort of legislations translate into practice, it's really hard to understand the sort of implications in practice. And that is really what's really matters to me. What is the practical reality that we need to work in 5 years' time, for instance? So we need to start testing, I think.
Yeah, and that you showed already that you are doing to a certain extent.
Yeah, but we need to make sure that we look into the proposals, see in what direction do they go, and try to do things in that direction. Try to test.
Yeah. Great. Marcus, you mentioned the medical device regulation. And one of the questions from online was like, how do you connect continuous learning models, as also mentioned in the previous session, with the medical device regulation on the other side?
Well, that is clearly a super challenging issue from a legal perspective, and I think that liability will be a core topic going forward, implementing those new models that are continuously developing themselves even. And the approach that we have today when we use large language models in practice, which we are doing now, is that we try to take care about the liability issue by having clinicians in the loop all the time and taking the responsibility for the output of the models. So there is still someone, physical person, to hang when things go wrong. But that's the system we've built. That's the responsibility that the safeguards that society built into the regulatory framework in place today. And I don't see an alternative to that in any close time, actually, because still our patients trust the doctor more than the model. That will change probably over time, and we see now that even doctors in recent studies trust the responses to patients more than the responses to patients produced by human doctors. So both in terms of ethics and the facts provided within the responses to the patient. So I think the things will shift, but in the near future, the responsibility is still on the clinician and on the management, the human persons, validating and accepting or discarding the output of the models.
Now that is for a clinical setting. If we go to a preclinical setting, drug development, who's there to hang, to use the analogy?
Yeah, so this is also a difficult one for us to navigate, especially because we work with vendors, we work with partners. That's the reality. We also do a lot of development in-house. So one of our principles is really to have a person accountable, and you have to assign who that person is accountable, whether it's us, our partner, or user, a developer. But that's one of the questions that we always have, and it's becoming more challenging with widely consumable, available tools, because you cannot necessarily just put that on the developer of the tool, especially when it's public, and especially when multiple tools, AI tools, are used in a pipeline that's built together with many different developers, or even companies that have not necessarily making a private bespoke tool for us. So one of the big challenges there also is to try and assign accountability to the user and how that works. And a lot of that has to do with training, enablement, and confidence building, and knowing where to go if you need to change something, how to make your decision, using that human logic and making sure that that human override is still there. So there's a lot of trust building. I'd say more, not trust building as much as confidence building in our employees as well, to be able to make those decisions and feel confident, comfortable doing so, using these AI tools and still taking accountability on their own.
And now you say user. Do you mean by that a professional user, a doctor, or do you mean by that the patient's him or herself as well?
It can mean anyone. It could be the user making an internal decision within Astra Zeneca as to say the safety or efficacy of a drug within a clinical trial. If you're using a tool to help make that decision, you're a user, not selling a AI tool necessarily to the public, but making a decision towards the development of a drug. So that could be anyone that's interacting or depending on the AI tool.
If you bring that to research and also the interaction, for instance, with low resource settings, what would be the proof, or do you already know of any proofs of concepts for AI-based global health that really is applicable in, let's say, we're at a very rich setting today?
Yeah, I mean the issues for AI in the global healthcare sector, of course, it's difficult to generalize globally. But one of the concerns that is raised, at least in the academic phase, is the availability and type of data that are used to train machine learning to develop the algorithms. May well be based on data collected in the usual places in Western Europe or the US or whatever, and the issue arises to the relevance of those data and the AI tools emerging to other populations, because of genetic variation or environmental changes or whatever. And in most cases, of course, we don't know much about that relevance. So there's, there are issues to face there. But there's another issue that also may become more prevalent in the global setting. Essentially, it's consumer healthcare. I mean, we talk about the things that are regulated by medical devices regulation or by medical pharmaceutical strategies, but of course there is a potential growth market for AI in various ways for consumer healthcare. And the extent to which the consumer understands the risks and the benefits or is informed about those is questionable. And I'll give you an analogy with the in vitro diagnostics regulation. We went through a lot of discussion. But of course, it doesn't really touch the issues for direct-to-consumer genetic testing, because that can be obtained outside of the provisions of that regulation through the internet or whatever. So again, there may be a concern that however many regulations you have for medical devices or AI product liability or whatever, these may get circumvented by new methods of procurement at the consumer level. So I think, obviously it's important for all patients, to understand to the extent that they can and informed consent. It's always going to be difficult for the patient or consumer to validate. They can't validate for themselves the technology, so they're relying on, they're trusting the company or the device manufacturer or the prescribing clinician. But when it comes to consumer healthcare, those safety valves may not actually be in existence to the same extent.
You touch upon the consumer or the healthy citizen side pretty much now. In my work, I'm head of a department where we also have sports technology, for instance, and their AI development goes very fast.
Yeah.
Now, one of those things is if you push a sportsman to sport even harder, what is your perspective on the risk classification, for instance, under the AI Act? When does it need to become a high-risk activity? Because I might have an underlying heart disease that actually pushes me over the cliff.
I don't have an answer to that question. But I forgot to mention in my previous answer the global dimension that you asked about. And consumer healthcare may become increasingly important in the global setting because, of course, as it were, conventional healthcare facilities may not currently be available in some lower income countries in the way that they are in Sweden and Europe. Hence, that there may be more enthusiasm for consumer healthcare delivered by through other settings. But sorry, I can't answer the sports. I'd have to think about that a little longer. I'll come back to you on that later.
Yes. Marcus.
I would say that risk is perceived in very different ways by different individuals. So I think the important part here is actually to understand what risk you are taking by using a solution. And sometimes we as physicians, we have no clue how the drug was developed. We just need to trust it. And that we do by understanding it well enough. And I think that will be the way going forward regarding even consumer related AI, that we need a framework that describes the risk, the benefits, and on a very understandable level to the layman, so that they can themselves make the choice whether or not to use it. Because risk aversion is very individual, and we see that all the time in healthcare.
Good point. Regarding trust, if I may shift to you, Magnus. Yep. You mentioned about the large-scale language models and the ChatGPT of medical language. How easy is this to integrate? How can they be biased? And one of my personal pet peeves is we know how bad the quality of much data is actually underlying. So what is your perspective there?
Yeah, I mean, definitely. I mean, to be a little bit hypothetical, theoretical, everything is biased to some extent. So, so there's nothing that is 100% non-biased. And I think data quality is, of course, important, but that is also something that is really rather hard to measure. To have like a quality measure, and But I mean, to be transparent about what type of data, training data you have is of course really important, and that is something lacking when it comes to ChatGPT, for instance. We don't know, and probably it's almost everything out there, good or bad, I don't know, but it's sort of difficult in terms of transparency and trust. I think the other thing that is important there is that we need to have, like, if we don't get transparency in terms of understanding the data quality or the processes of how AI solutions have been trained, etc., as users or consumers or whatever you call us, we need to make sure that we have a process of validating with sort of the important aspects from our side. And I think that is something when we think about commercial already CE marked products, for instance. They have been trained somewhere, they perform brilliantly somewhere. We don't know if they work for us. We need to make sure that they actually work in our settings, with our ways of working, with the patients we have, etc. So even though we don't have like full control over how the models were developed, we still have a sort of responsibility of understanding if they really work and do the things they're supposed to do.
If we moved out to you, Margie, and we would add a word compliance, which from an industry perspective is super important, how will you resonate?
Yeah, that's a great question, because compliance is the first step in what we want to do, but it's not the end goal, because we still want to drive trust. We want to drive trust from our patients, our shareholders, but we also want to trust the decisions that we make. So compliance is one aspect where we're trying to understand the limitations, the benefits, and the power really of these tools that are publicly consumable, such as ChatGPT, and the benefits that we can realize within the ways we work, but also where do we know when to trust it, and where do we know when we need to apply a second opinion or human judgment over rule again. Tying that to the compliance aspect, we want to be, eventually when we're doing research and development, we are submitting to health authorities to get a drug or an indication approved, right? And so there's a compliance aspect there of how do we make these decisions, this internal decision-making piece that is in R&D using these tools. How do we tie that to use that to justify the use of these tools, and can we trust those decisions when we want to comply with authorities and report to authorities in order to have our drugs approved as well? So there's quite a few questions there that we are navigating internally, and that's where the training and development of our employees is most important, to be able to use those tools wisely. Additionally, that's a difficult one, to be honest, the compliance piece. It's something that we're constantly navigating and constantly changing as the laws and interpretations change. And this is also where we want to work together with lawmakers to understand what are the implications and where we need more guidance to be compliant, but also drive trust.
And do you see a role for not specifically one company, but let's say the pharmaceutical industry, to also educate the users on how to work with compliance, what is your role there to maintain the trust?
With compliance. Yeah. So one thing that you can do is things like auditing internally to see what are we doing right, what are we doing wrong, and where can we improve in that compliance, and then learn from other companies. So a lot of lessons learned sharing, I think, fosters a culture of questioning yourselves, which I think leads to that trust, because you're trying to do this right. You're not trying to take the fastest, easiest route forward. And I think that's being open and being candid about how you're learning as the laws, the regulations, and also the technologies develop quickly. I think that can foster that trust and enable that compliance as we're sharing more openly about how we're on this journey together.
But together, there's also a clinical implementation perspective there. The public sector, do you know enough to be able to use this, or where would you need a joint support or a joint program to be able to educate, to change procedures? Looking at both of you.
I would say that the span between the most knowledgeable and the least knowledgeable in this field is huge. So you have champions at one end, quite understanding about this technology and how to use it and where the limits are, and then there are others, and probably the majority, who have huge difficulties even understanding what artificial intelligence is. So we clearly need a guidance and educational efforts for this to push forward on a broad scale. I just want to comment on one thing. We touched on the word bias before, and we need to remember that the most biased intelligence we have is the natural one. So, and at least in artificial intelligence, based on the bias data that we use, we can measure the bias and compensate for it. So it's a great chance that going forward in a number of years, the output from the model will be less biased than we ourselves are, because if we are aware of our biases, we can compensate for them in the data. And that we see now that we produce synthetic data, so that we can compensate for ethnic minorities, etc. And that we as humans cannot do by just thinking.
That is a very important point you make. To going a little bit further on the compliance versus risk management thing, Magnus, if you think about the difference between AI for operational things, as you mentioned, and the AI for medical things.
Yes.
Just taking an example, there are a lot of hotels that are applying optimization of bed sheet changing now. If we translate that to the hospital, would it need to be regulated as a high-risk thing or as a hotel? What is your perspective?
My sort of gut feeling is no, I don't think that is high-risk AI. But then again, I'm not really sure how to interpret the AI Act, to be honest. I mean, anything that we do, or most things that we do, will affect the individual either directly or in somehow indirectly, and there is like a risk that even though that what we actually that affects the individual indirectly might have a lot of big consequences, and that is, I mean, perhaps not changing the bed sheets, I doubt, but you never know. But there might be other cases where the consequences might be so big that this might actually be something high risk. But yeah, I'm not entirely sure.
Well, there's room to explore.
Yeah.
Are there questions here? I see a question coming. Yes. Thank you, human firewall, to the online chat. What can we do about AI algorithms on medical data that is developed on limited cohorts and therefore not enriched for exactly what you mentioned, like minorities, etc. So how can you ensure that those can be trusted? I think there's a research perspective on that and a global company perspective as well as.
I mean, as I mentioned, I mean, it is said to be an issue. I mean, notwithstanding the points you made about ethnic minorities and so on, in some respects, you know, it is considered to be an issue with regard to potential bias in the availability of data to train the algorithms. And actually, thinking back on my past experience, you know, quite often some of the quality problems in other settings relates to the quality of phenotypic data. That's in the UK, for example, been quite difficult to build gene disease associations, for example, using the general practice data because of the variability in diagnosis certainly at the primary care level, which is why the UK one reason why the UK set up large biobanks studies with particular clinical diagnosis associated with a collection of those data, because they couldn't rely even on what one might think, you know, relatively simple diagnoses like myocardial infarction in order to calibrate the data. So there's all sorts of potential biases in doing it. But certainly I think coming back to the title of this event and the global health, which I don't think we've talked too much about, and obviously a lot of the experiences in the EU. But it would be interesting to think further about how the EU experience can drive the opportunities for global health. We have the AI Act, which is a global first, and EU is in a leadership position in various respects with regard to the use of clinical research data in all sorts of applications. We do have access to large cohorts. Many of our health systems do collect data across populations, not necessarily seen in countries such as the US. So we do have great resources across Europe. How can we use that to drive the global health in the AI setting? I'd like to hear more about that maybe, but rather than supply the answers. I don't know.
I saw all of you taking a note. You were the first with a finger.
Okay, sorry. Yeah, I just want to comment on that because I think what we are dealing with quite often is what's called real-world data from our clinical systems. And even though we might get quite large sample numbers, the data quality and the sort of coverage in terms of what variables we are really interested in collecting is perhaps not there. So it's not a matter of just getting high number of samples. It's a matter of understanding your data set as a total. But I know, I mean, in AI in general, we need more. The more data, the better. I think is a good rule of thumb.
Yeah, and I think one part of the answer is that you actually need to test the model in the local setting to understand its performance. And we are together in different projects now understanding transferability costs of AI models. And what we can see is that even if we think our healthcare systems and hospital systems are very much alike, the data differ to some degree, and we lose about 20% predictive performance when we transfer models into new settings. But what I think is important here is that I don't know how experienced you are with AI, but you can then look at the transfer model as pre-trained. So re-achieving the last 20% in the new local setting is not that hard because the pre-training was already made. So I think that we can find systems for generalizing locally developed models, but you need to be aware of the loss of performance when you move it and know how to compensate for that and fine-tune the models locally.
And if you say that, what is the relation between that and the standardization of European health records, where to a certain extent you lose the local explainability because of a level of standardization? I find that a difficult balancing act.
Well, standardized data is always better than not unstandardized data, but now we're talking about structured data. When we move into unstructured data, free text, then the structure is not that interesting anymore, and we dive into large language models where the structure of data is of less importance, and at least in the sense that we think of tabular data and that kind of classic data types. So I think that will be a problem that will pass over time, and we need to look directly into the performance of the models instead of how they were built.
Important point. Margie.
Yeah, just thinking back to the original question of the data set used to train a model standardized to different communities and cultures and that sort of thing. So if you think about the diversity, equity, inclusion textbook, you'd say the the answer there is to diversify that data, diversify the minds in the room who are developing that algorithm, right? Not always possible, but there are ways we can influence that by educating and empowering patients so that they feel more comfortable, confident with that data sharing. That can go part and parcel with the EHDS as well, so that you get access to more of that data. And in you understanding the culture in which you're implementing these algorithms, because implementation looks different in, say, a ethnic minority community in one country versus a different one as well. So putting in as much context as you can in your decision making, and also empowering the healthcare provider or whoever it is using the AI solution by disclosing the strengths and limitations of that AI system, how it was trained, where you may need to put in some level of additional judgment until that model can be trained, or as Marcus said, until you can take it that extra 20% to apply it in the correct context correctly. So I think the patient empowerment piece to share their data, and also the user empowerment to make that judgment call of how and when to apply, so that you have the most equitable and realistic outcomes when applying into new communities.
And we were a little bit into criteria for risk assessment. The current AI Act has these example categorizations. What are your perspectives on how do we need to develop these criteria? What would be optimal from your perspective? If we start with a bit more researchy.
Yeah, well, I guess you ask a researcher, we always need more research. Is the answer. But,
yes.
But beyond that, I mean, I really don't have much, more to add to what I've already said in terms of the AI Act. I guess I would emphasise the point again that the AI Act is the first of the global pieces of legislation in this area. We must be mindful of the global context in which we're seeking to develop that act and implement it.
And you, Margie?
Yeah, so examples are always helpful. Examples are what we use internally also when translating our AI principles and legislations that are coming through into guidance internally for what our employees should do. Examples of what needs some additional oversight and governance versus what doesn't. But that's never going to cover every single situation that comes up or every single algorithm that comes up. So again, education, training, and also any interpretation, maybe a an industry or a health industry, public and private, best practices that could be built across sectors to understand how to apply this more practically with examples, but also put your own thinking on top, I think would be very helpful, and that's something that we as AstraZeneca definitely advocate for, are willing to contribute to as well. So examples are great, but they are a guide to the user to put their own thinking on top as well.
And for you in the Swedish context, you even moved hats at the same time.
From my end, I think harmonizing with the already existing regulations like MDR, for instance, so that the classifications in the MDR sort of harmonizes as good as possible with the AI Act. Because if we get conflicting legislations, we have problems both how to interpret, but also internal competence, etc. that needs to, so we can understand and we can work with these legislations.
That leads into the question of the AI Act is a general act, whereas EHDS obviously is health. And one of the things I've previously worked in some other sectors is health is different all of the time. To what extent is health different when it comes to the AI Act? Do you maybe understand my question? Do we need something additional, or do we need exceptions, or do we need, because health is also regulated by so many other things?
Yeah, I can maybe add that in healthcare, risks are intentional. We take risks intentionally, but they are calculated. And that is maybe differs a bit from other sectors in healthcare, but or in society. In terms of healthcare, it's more important not to take away opportunities, but to be transparent about the risks, because we again, risk perception and risk aversion is very, very individual. So when we use a tool, if we know the risk, if we use a pharmaceutical, if we know the risk, we're prepared to take that risk together with the patient. But we need to know the risk, the level of the risk. And I think that is something you don't think about when you put yourself in a car and you say, well, there is one risk in 1,000 that will be part of an accident now, because you don't have that specification of the level of risk. But in healthcare, we do. And we take those risks in a very, very calculated way.
My wife and I have a little bit macabre humor. Every time I get into the car, hope to see you again. But yeah, it's not very common.
Just add that, of course, health is an issue not just for the healthcare sector. It is a cross-sectoral issue, and perhaps in the context of the broader development of AI and the AI Act, we ought to remember that one of the first impacts of AI practices is actually on occupational health and safety. We're beginning to see quite a lot of examples of use of AI technologies in hiring decisions, for example, worldwide, that have the potential to discriminate against minorities. So there's issues for equity and health equity, the use of AI in improving or worsening working practices with consequences for occupational health and safety. There's a number of issues associated with AI. I just want to emphasise that it's not just a matter for AI use in the healthcare sector. AI use in other sectors has big implications for health.
Definitely, definitely. A last question to all four of you to answer. As you were into, Magnus, things have been developing very, very quickly over the past year. The terminology that we use, the discussions that we have been scaled up, matured a lot. From your perspective, in 1 year, what will be the hot question then that we haven't thought of as of now? A little bit of future thinking. Marcus.
I can start. I think we will be sitting here wondering what happened outside the world we know as healthcare people, because these tools will be made available. ChatGPT is already being made available, and things are happening outside our radar. And understanding what's happening outside the radar is much more intriguing and difficult than understanding what we're actually doing, because that we can handle and we can understand. So understanding the development outside our radar will be the challenge for us the coming year, I guess.
That's a very clear message. Do you have an additional one?
Actually, I don't do any manual forecasts. I just use AI for doing that. So I think I passed on that one.
Margie, do you need ChatGPT to generate an answer, or do you have an idea yourself?
Well, I tried to give a talk on ChatGPT a couple of weeks ago and used ChatGPT to give a title for the talk. I didn't like it. So so I have my human override usually. So what's the hot question in 1 year? I can see two of them, honestly. One is there's going to be a heavy polarization of use and understanding of these AI tools in terms of those who use it regularly and those who do not, and how to bridge that gap. But another is the cocktail of mass consumable AI tools that will be available much faster and to use in tandem when driving decisions and enacting those decisions and how to trust those and the interplay between those. I think that's something that's developing much faster than we initially thought. I mean, I think there was the AI winter that we were expecting that is no longer a concern from 1 year ago. I think it's the interplay of all of them together, which will be something we all need to work through, public and private, and how to maintain that trust and confidence.
Thank you. Robin, the last word is yours.
Well, yeah, I think I'd hesitate to predict a year ahead in such a rapidly developing area. But I'd perhaps just mention one thing that I don't think's come up. It would be nice in a year's time if we know more about the potential value of using AI, essentially in social media, to get earlier intelligence on new pandemics and epidemics. You know, would AI have improved the rapid response to COVID? Sure, that's something that Astra Zeneca has thought about in terms of vaccine development. You know, we're beginning to worry now about, for example, new variants of avian flu that will be transmissible to man. That's very likely. Can AI help in that intelligence gathering? Possibly. It's almost the step before the R&D pipeline that you mentioned earlier on. Intelligence gathering on, you know, what's the next problem in health.
That is an outlook. With that, I would like to thank you in the panel. Great.
Okay, thank you.
Please come back, and then we'll try to summarize and get some call to actions, which is not entirely easy. Luckily, I don't have to do it alone. Frederik Heinz, you work for AI Sweden as well as for Linköping University. You've been listening and taking notes. Could you share some first responses?
Sure. No, so I mean, I think the first and foremost is that, AI is here now. It's not, I hear still a lot about future. I think that's still very interesting. It's very much, this will happen, but I actually think it's here now. So it's not a question about the future. It's a question about the past, not the past, but well, the past too, but really about the present. I really think that's the number one thing. And I also think that AI will really be a key technology for solving the challenges that we are facing. And I think that's another. But I also think it's very important that it will not be the only technology. So it will be one of the technologies, but I really think it is key. What I also hear was this, which was actually also mentioned during the last 2 days here, the previous 2 days, and that it's how do we go from curing disease to preventing disease? So kind of shifting the mindset. But I also think another part of this is that there's one way, or one aspect is to use technology to do what we did before, but faster or better, higher quality, cheaper, and improving what we have already, or what we're currently already doing. But it's a different thing to do something that we couldn't do before. So it's about opening new possibilities that didn't exist before, which I think is the much more interesting aspect. And it's also, I would say, related to this transformative aspect, that transforming the way that we do things so we can do new things. Of course, what has been lifted up is that data is one of the keys to really support this. So of course, there's been a lot of mention about, for example, about quality, interoperability, and I really think what was also mentioned is semantic interoperability is as important, if maybe not more important, than just being able to send data back and forth, or to have kind of know what the columns of the tables are, but that doesn't mean that the content is actually the same. So it doesn't mean the same thing. So semantics, I think, is really, really important. We've also heard about many different types of technologies. Privacy-preserving technologies. We mentioned here lastly about transfer learning. How do we take what we learn in one setting and use it in different settings so we can reduce the need for data? We have synthetic data that hasn't been mentioned that much today, but I think that's another way of how do we reduce the dependence on data, or how do we take more advantage of the data that we already have. I think this issue with continuous learning was also very interesting, because we know that most of these phenomena are non-stationary. So it means that they change over time, which means that we cannot just take a model that's trained at one point in time and then just continue using it. I mean, this I think it's also interesting with this ChatGPT that has been mentioned a number of times, because I mean that's trained on at one particular time point on data that has been collected up to some point, which means that everything that happened after that, it's completely oblivious to. And I think that's very important to remember. I also really like the 11 barriers that Marcus talked about. That 6 was about legal, 3 about semantics, 1 technical, and 1 about trust. And maybe that's a good, I mean, basically it's 6, half of them, more than half, it's about legal questions. I think that's quite interesting. And then the second quarter was about semantics, which I think we haven't talked that much about, but I really think that's important as well. Then of course we have the question of how do we achieve this trust? And I mean, regulation is just one way of achieving trust, but it seems like a lot of focus is put on that. And one thought I had was that isn't regulation the opposite of trust? If we trusted people, we wouldn't need regulation. So isn't the whole point of regulation is that we don't trust? So we need to replace trust with regulation. I find that very problematic because I think here I have a hypothesis, I have many, and that's I think the more regulation we have, the less trust we will generate. And we will focus more on, because the implicit argument, or the implicit, understanding is that if it's not regulated, it's allowed. And I think that's another false assumption. Just because there is not a law forbidding you to do it, it doesn't mean that it's a good thing to do. It could still be immoral or otherwise, something you shouldn't do. So I actually think we have this problem, and we see it more and more that, it's not a rule. Okay, then I do it. So I would say regulation might also decrease trust. We also talked about standardization, certification, and all these kind of things to achieve things. But one thing that was, I think, only heard mentioned one time, which I think is actually one of the key challenges, that's verification and validation. So how do we actually validate that these systems work and that they do what we intend them to do? And I really think this is really a hard problem. And the example I've always been using, or at least for several years, is this with this Go games that was played like in 2016, I think it was, where the computer beat the humans in Go. So it was clearly that the computer program was better than the people. But what was interesting was to observe the human expert commentators commentating these games. Because there were several times during these games where the commentator basically said, haha, the computer made a mistake. A human would never play like that. And here we have this very interesting situation where objectively it's a good move. The computer won. But from our best human expert's perspective, it looked like a bad move. Now the question becomes, this is just Go, so it doesn't really matter that much, for most people at least. But now assume it's a medical recommendation system. And that the system makes a recommendation that the expert human doctor just feel that doesn't make any sense from my perspective, from my knowledge, and so on. But then the interesting question becomes, on what grounds should this doctor either choose to follow the recommendation or to not follow the recommendation? We have to remember, there is no neutral choice. Both can go wrong. So it doesn't matter which, both of them have risks. We talked about, risks was mentioned here at the end. But that the doctor needs to make a choice. And that's where, on what grounds should that choice be made? I think that's a very non-obvious question. Because you can assume that these systems have consumed significantly more information than any human has ever been able to do. So it's probably not a matter of just information. Then it probably has more. But it could be other things that it did not take into consideration, for example. So I really think that's one of the really key challenges. And of course, this also applies not only to the doctors, but also to patients and everyone else. And here I think we need to have better ways of evaluating these systems. And here I think we need to have appropriate baselines. So what are we comparing to? I often feel that we are comparing not against the best humans, but towards perfect. And if it's not perfect, then it's broken. And I think that's probably not what's in our best interests, but rather, of course, we want to make it significantly better than the existing people. And then, of course, the interesting question becomes, so assuming that this system is better than the average doctor, is it then better to use it? On average, it's better. But of course, no one believes they're average. Everyone believes they're above average. So I really think this is interesting. At what level would we expect it to work? I mean, is it 90 percentile? Is it 95? It has to be better than the best human before we use it. Again, I think that's a very interesting question to discuss, and that probably much more constructive than to expect the systems to be perfect. And kind of to conclude, I also think one thing that I haven't heard mentioned here that much is this, that I don't think it's a question of either AI or humans, but it's really about AI and humans together. And I mean, the example I've been using here for also, again, many, many years is chess. Because humans haven't had a chance against chess-playing computers since, what is it, 1997, I believe, when Garry Kasparov lost against IBM Deep Blue. But still, if we look at today, human chess playing has never been as good as it is now, because we train against the computers. It's even claimed that Magnus Carlsen is the best chess player in the world, because he's the one that is best at emulating the way the computer plays, and that he's playing against the computer since he was a child. And it's also interesting that the interest for chess hasn't been higher. So it's clear, I mean, it doesn't make us worse. It doesn't reduce the interest in chess. However, no one cares about computers playing against each other. That's completely pointless to watch. So it has to be a human involved. But actually, what's more interesting is to Garry Kasparov, after he lost, he was very upset, and he thought they cheated and all kinds of stuff. But then he realized that, maybe I have to accept this. And then first of all, he started to make chess-playing programs. So I think he made a fortune out of that. But what he also did was that he organized competitions where humans, together with chess-playing programs, were playing against both humans and other chess-playing programs. And they turned out to be better than both the best humans and the best chess-playing programs. So the combination was better than either on their own. And I actually think also that if you had multiple people, that could also improve it. So actually teams of people were better than individual people with this. But I think there's also some very important lessons from this, and that it's a different skill to play chess and doing these kind of things with the AI tool than it is to do it without it. Which means that you can take the best possible tool there is and the best possible expert you have, and you put them together, and the result is worse. So it's a different skill to do the same thing with the tools as it is doing it without them. Which means that we need to do much more about competence development. It's just not, because I mean today it's very much focused on buying equipment and having the apps and the computers and the hardware and all this stuff, but we don't focus that much on the competence. How do we actually use them? And also, how do we adapt our organizations to take advantage of this? So we actually get the organizational change, not only the technology change. And I mean, that was also mentioned during these last 2 days, that technology change is easy, or developing and changing technology is quite easy. Developing and changing people and human organizations, that's a much harder problem. And I think, again, that's probably where we can have more to gain than just focusing on the technology. And to conclude, I think AI will not outcompete people. However, people that effectively use AI will outcompete those that don't. Thank you.
I saw a lot of smiles when you were trying to make specific points. What I tried to do is to capture a little bit what we've heard today, also specific to the health, global health context here. One of the things was very clear is the difference between legislation and guidelines. That we need more work on guidelines, also because of how fast this field develops, and that this is something where we need to jointly work, and that maybe could counteract your argument that too much legislation might reduce trust, but an adherence to guidelines that we all understand is super important, not the least when it comes to transparency for clinical trials. Multiple people mentioned those clinical trials during the day, of how important it is to have the decision making there transparent regarding guidelines. Multiple times it's been mentioned about how GDPR implementation has faltered or has been difficult. I believe that we need to try to learn a little bit from that now when implementing particularly EHDS. Marcus, you were into those things as well. How do we organize this learning process? Is that organized? That I haven't heard so far. So maybe a bit of collaborative learning there could be in place. The bias of AI. Many people went into that, and the bias of AI, of course, could be less than how much we are biased. But are we accepting a bias of a machine versus the bias that we have ourselves? There maybe the hybrid combination that you propose actually could become a winning factor.
May I comment on that?
Yes, please.
So I mean, I made the same argument before, and then the only good counter argument I've heard so far is actually that we humans, we know that we are biased, we know that we make mistakes all the time, so therefore what we have done is that it's not just a single person making a decision, but we build these systems around it, and there are structured ways of dealing with errors or bias and so on, so that we have this kind of onion principle and kind of different systems on top, and if you feel that you have been wrong, then you can overrule or go to court or something. So I mean, actually I think what we need to do is that we shouldn't look at these AI systems as completely on their own, but that they're part of these socio-technical systems, and that we should basically treat them similar. I don't think we should treat them as people, but that, I mean, the way that we deal with the fact that we also make mistakes, that it's not just the system itself, but we need to put it in as part of the systems that can systematically deal with these challenges.
Yes. And then I've heard multiple things about the specific complexities of health, because health is regulated by so many different regulations. We cannot just put something just under the AI Act. We also have the medical device regulation, and we have this, and we have that. Many guidelines there as well, national legislations. The conflicts between those appear to be not entirely clear yet. So I suspect that in the forthcoming year we'll have to look into where do these things actually clash, both at the EU level as well as at the national level. But what do we need to learn? What do we need to learn collectively? And where do we need to raise the lowest level that we have? In the last panel, it was also like the specialists really know what the state of the art is, whereas the lowest level that we have in the health and the healthcare sector is very, very low. Is there a minimum level that we need? And where do we need to move the average? That seems to be something that is next on the table as an action to take forward. Any final thoughts from you?
No, but I mean, sometimes I get asked, I mean, so what do we really need to do? And I really think education is one thing. I mean, I think it's, to a large degree, it's an educational issue, and that we need to raise both the understanding and the awareness, both with the specialists, but also with the broader population. But I also think it's about working together. So really this having these ecosystems and collaborating, because no organization will be able to do this on their own. But if we help each other out and actually work together, I think we have a chance.
Good. That brings me back to the triangle of trust that we started with. I hope that for those of you participating here today physically, that you have a little bit more trust in our collective intelligence on how to bring this forward. And for those of you online, I hope you trust we'll have a good lunch. Thank you for participating. Thank you all for shaping this up. Here we close it. Thanks.